from the different parts of the world. I am Dr. Shubham, presenting my topics: expandable metallic stenting for advanced tract malignancy and effective palliation to the obstructions. And I am from the National Institute of Cancer Research Hospital, which is a tertiary cancer hospital center of Dhaka city, Bangladesh. And today's my presentation are about malignant GI tract obstruction and management options, endoscopic stenting, indications, complications, advantages, result of an observational study, and at an ICRH. So, malignant GI tract obstructions is typically defined as a mechanical blockage of the lumen from esophagus to rectum as a result of malignant tumor, usually seen in advanced unresectable gastrointestinal cancers. Progressive obstructive symptoms such as regurgitation, intractable vomiting, dehydration, abdominal pain and distension, absolute constipation, liver shock, and protein calorie malnutrition are the usual presentations. So, obstruction of GI tract malignancy are considered advanced stage. GI tract malignancy presenting with progressive dysphagia and metastases are uncurable disease, and patient may present with comorbid disease, sometimes unfit for surgery, and in operable cases there is no curative options. So palliative bypass or stenting are the only options before any definitive therapy. So the palliative options are feeding, gastrostomy, vaginestomy, percutaneous endoscopic gastrostomy, esophageal stenting, gastrostomy or duodenal stenting, ileostomy, colostomy or colonic stenting, enteral or intravenous hyperalimentation. Classic stent is the obstructing advantage. Advanced GI tract malignancy in view of bypass surgery can offer palliation in metastatic disease as well as symptoms relief due to obstruction in locally advanced case, unfit for surgery or before neoadjuvant therapy. The decision must be made by multidisciplinary tumor board which palliative options will be appropriate for relieving obstruction before definitive. And the stent type must be selected on an individual basis. In most cases, technical and clinical success of esophageal or gastroduodenal stenting is about 90%. There are different types of stents, gastrointestinal stents, like anti-reflux, some has anti-reflux valve, some has anti-migration double layer anti-reflux tube, and some are segmented stents. So these have some advantages and disadvantages. Like uncovered stents has low risk of migration, but it has high risk of tumor ingrowth. And for partially covered stents, intermediate risk of migration and tumor ingrowth. For fully covered stents, it's a low risk of tumor ingrowth, but high risk of migration. For plastic stents, safe and easy removal, no tumor ingrowth, but it has high risk of migration. So a multidisciplinary evaluation that includes the patient, the endosurgeons, and the oncologist before a route of feeding is chosen. A careful endoscopic evaluation for cancer location, length, and severity of the stenosis is mandatory before a feeding access is chosen. So patient selection is very important. Patients with curable disease are not the candidate for stents usually. Gastroduodenal stent placement is used to treat symptomatic patients with gastric outlet obstruction with unresectable or recurrent malignancies at anastomotic sites. Colonic stents usually have specific indications. Patients considered for stent placement should have a short life expectancy, usually 2 to 6 months, but maybe little longer. Patient with sepsis, bleeding diathesis, or peritoneal carcinoma, COVID-19 patients are not suitable candidates. And these are our endoscopic suite, oil equipped and oil furnished, and some accessories like diathermy, subregular dilator, pneumatic dilators, guide wire, and knives are usually required for this therapeutic procedure. This is a case of advanced esophageal cancer in the mid esophagus. There is almost obstruction of the lumen, and before going to any definitive therapy, obstruction should be relieved. And so, endoscopic balloon dilatation, pneumatic balloon dilatation was done over the structure, and after the dilatation, the structure is open, and over the guide wire, a stent, metallic stent is deployed. This is a case of malignant tract esophageal fistula due to esophagus, and It is because there is huge fistula and patient come with aspiration, and after cover stent, its fistula is open. And there is visit presentations. Um, sorry. Uh, the imaging presentation showing there is a large tracheoesophageal fistula, and patient condition was deteriorating, and it was done in our outpatient department, just with minimal sedation over the guide wire. Stent is deployed, and patient just admitted in the hospital for 1 day, and after that, patient can drink for fluid, and patient condition improves. So this is a stenting has also a therapeutic indication also, and duodenal stent for malignant gastric outlet obstruction for patients in whom disease has reached the point of causing luminal narrowing. Oncology resection is often not feasible or may first require adjuvant therapy. Therefore, endoscopic stent placement offers serves a palliative role. This is the barium meal stomach, showing there is a hugely distended stomach due to distal obstruction in the antrum, and the CT scan also shows distended stomach, and there is a thickening of the antrum showing obstructions. So the urinary stent was done by endoscopic guidance, and by fluoroscopic guidance, the position of the stent is ensured. There is no displacement. This also can be done by small sedation. No general anesthesia is required. Colonic stent, expanding metal stent represent an established alternative to surgery for the palliation of unresectable colon cancer, and currently allow a bridge to surgery strategy to relieve large bowel obstruction and optimize the patient clinical condition before selective surgery. Indications are the palliations of the colorectal carcinoma-related bowel obstruction in non-operative candidates, non-resectable malignant structure, local post-operative neoplastic recurrence, and sometimes active risk to surgery for decompression of the obstructive bowel, relief of large bowel obstruction for extracolonic colonic malignancy, pelvic mass of peritoneal carcinomatosis, malignant colorectal fistula, and sometimes post-operative anastomotic leakage and fistula. The stents are a little bit wider than upper GI tract stents because of wide caliber of the lumen, and this is a case of colonic obstruction due to growth in the rectosigmoid junctions, and stent is deployed and placed, and just after the stent placement, obstruction relief within minutes. And this is the final picture, CT scan of the abdomen showing decompression of the bowel after stenting. So the outcome is almost better than the palliative bypass surgery. Patient can take intact fluid just after the procedure, and operative time is minimal, just half an hour, and the patient can be discharged from the outpatient department. No major complication was seen, and long-term relief is maybe required randomized control trial, and quality of life is increased. So these are some complications like the procedural complications like sedation, pulmonary aspiration, stent malposition, perforation, and bleeding. But the late complications may also troublesome, but it can be managed endoscopically, like tumor overgrowth, stent migration, fistulation, especially after the post chemotherapy, radiotherapy. So regrowth of tumor is a challenge, but we can manage it by endoscopically placing a stent over a stent, and the other option not that we can place a stent over the stent. Sometimes there is a migration of duodenal stent and causing intestinal obstruction, require laparotomy. This is the case of duodenal stent migration to DC junctions, and we go for laparotomy and resection and anastomosis of the bowel should done. So this is our topics presented published in our Journal of Bangladesh College of Physician and Surgeon in July 2024. The objective of the study is to review the experience at tertiary cancer hospital and short-term outcome with endoscopic stenting in lieu of palliative bypass surgery for advanced and obstructive GA-type malignancy. It is an observational study done in the surgical outpatient department of National Institute of Cancer Research Hospital, where all therapeutic endoscopic facilities are available. All patients were treated with stenting in a 2 years period from 2018 to 2019, and including the corona period. So the results is that 56 patients having stents of 60 stents, and results is overwhelming. Minimal complications like perforations, clogging, in overgrowth or dislocation that can be managed by endoscopically. And the survival is better in case of colonic stent, less in case of stomach or duodenal stent, because the tumor biology, the tumor are more aggressive in case of upper GA tract than lower GA tract. And the survival is was almost 100% in case of colon over observation of 1 year follow-up, and but less in case of upper GA tract due to tumor biology aggressiveness. So in conclusion, the present series shows that placement of expandable metallic stents in the obstructive GA tract malignancy as an alternative to bypass surgery is safe, cost-effective, less complications, less hospital stay, and provides good palliation. And if adjunct chemo or radiotherapy given, lengthens life. Also recommended proper counseling of the patients and proper therapeutic endoscopic training from the surgeon's part before palliative stenting. So this is a glimpse of our activities in our institutions as a daily routine practice, and recently we have started PRCP stenting for management biliary obstructions. And these are our team. These are our activities. Duodenal stent for CA colonic stent for CA colon, and this is a case of transverse colon malignancy with liver mets. And after that, the patient can get palliative chemotherapy. Mostly esophageal stenting is done like 46, and gastroduodenal stenting are 10, and colonic stent are 2. So our recommendation is that self-acceptable metallic stenting would be a safe alternative palliation to bypass surgery for advanced GA tract malignancy. Randomized control trial are needed to assess its efficacy, cost-benefit, success rate, long-term survival outcome. Basic endoscopic training, minimal endoscopic setup, minimal equipment and accessories, and a dedicated team are required for successful therapeutic endoscopic procedure. So the home message is that for management of GA tract malignancy, surgeons should think for therapeutic endoscopic evaluation and self-expandable metallic stenting before going for bypass surgery. So and this is the hope. Thank you very much. Thank you everybody for questions.
Student and a lecturer in the university. Today I will be presenting the findings of our study on investigation of dose optimization of stereotactic radiosurgery methods in multiple brain lesions. This study was originally my master thesis, and it was conducted approximately 6 years ago. It's a great pleasure for me to share with you. As we all know, cancer is a disease in which some of the body's cells grow uncontrollable. Brain metastases are one of the most common types of brain tumors, and it occurs in 20 to 40% of the patients with cancer. Actually, one of the biggest challenges in treating brain metastasis is ensuring that sensitive areas such as the brain are protected. In this presentation, we will explore how dose optimization is applied in stereotactic radiosurgery for the treatment of the brain metastasis. Actually, irradiation of the brain, especially hippocampus region, can lead to more cognitive deficits, and as a result, quality of the life of the patients is significantly affected. These cognitive functions include basic functions such as memory, attention, imagination. Surgery, chemotherapy, whole brain radiotherapy, and stereotactic radiosurgery are used in the treatment of the brain metastasis. In this study, we used stereotactic radiosurgery techniques. Stereotactic radiosurgery is a minimal invasive treatment for cancer, particularly for the treatment of the brain tumors or brain metastasis. These methods allows high dose of radiation to be focused on the tumors in sensitive areas such as brain. It can be applied 1 to 5 fractions. In this study, we used single fraction. Different devices can be used in stereotactic radiosurgery treatment. In our study, we used CyberKnife, tomotherapy, and linear accelerator. Actually, in this study, we performed hippocampus preserved plans on different devices using stereotactic radiosurgery techniques. For this purpose, we use CyberKnife, tomotherapy, and linear accelerator. And the results were evaluated and compared. You can see here we use RapidArc, CyberKnife, and tomotherapy devices in Turkey. In this study, we included 15 patients, and the 18 grade doses were given in a single fraction for each patient. We ensured that at least 95% of the prescription dose of all lesions, and the largest lesion was 3.5 centimeter diameter, and the smallest one is 1.14 centimeter, and the number of the lesions range from 2 to 5 lesions. When we looked at the VMAT plan, volumetric modulated arc therapy, firstly, we created PTV total volume, and then brain minus PTV total volume has been created for protecting the healthy brain tissue. And we used single isocenter for each plan, and 6 ME energy was used. And in this VMAT plan, we use the 4 arc angles. You can see here, and there were also table angles. In VMAT plan, you can see the arc angles in this image. In this screenshot, we can see the dose volume histogram and the dose coverage of the 18 grade doses of the PTV. When we looked at the CyberKnife plans, firstly, we created PTV volumes by giving a 2 millimeter margins to GTV volumes, and sequential planning option was used. 3D scale was selected, and we used ray tracing algorithm. In this image, we can see the dose volume histogram and the dose coverage of the PTV. It's belonged to same patient. When we looked at the tomotherapy plans, firstly, we ranked target volume and a critical organ in order of importance. We used convolution superposition algorithm. Also, we used 6 MV energy in all devices, and we use single isocenter in all devices. In this image, we can see tomotherapy plans of the image. There are also dose volume histogram and dose coverage of the PTV. In here, we can see 18 and 9 grade doses of the same patient. In this image, we can see the plans of the same patients on different devices. A is Eclipse, belongs to VMED. B is Multiplan, belongs to cyberKnife. C is tomotherapy, belongs to tomotherapy. When we looked at the doses received by 95% of the lesions, we obtained similar results with 3 devices. And then when we evaluated the dose decreases 2 centimeters beyond the lesions, VMED and cyberKnife plans were better. However, there was no significant difference between 3 devices. Here we can see the dose volume histograms of the same patient. I will talk about the doses of the critical organs in a moment. After all, we did a retrospective study. We made a comparison in terms of target coverage and protection of the critical organs. Most of the critical organs could be better protected in cyberKnife plants. These may be due to its collimator structure because its collimator structure different from other treatment devices. Organs such as lenses were better preserved in tomotherapy plants. Actually, tomotherapy had a feature where we could adjust input and output doses. That might be the reason. For instance, we didn't want to give the input dose through the lenses in our study. So in this case, the lenses could be protected more. When we evaluate the hippocampus doses, hippocampus was better preserved in tomotherapy plants, but the results were clinically acceptable for other devices. When we compared the plans of 3 devices, the most healthy brain tissue was obtained with the VMED plans. When we evaluate the monitor unit data, VMED plans gave better results. The shortest time was obtained with VMED. And as a result, there are acceptable results for target and critical organ doses in 3 different treatment devices. Thank you. Is there any question?
Intern in NRCH, Delhi. So my case is, my topic of presentation is cardiac sarcoidosis, presenting as multiple right intra-atrial masses mimicking cardiac tumor. Written by Jay Gauri, Harshvardhan Luthra, Khushbu Qureshi, and Karanti Purudveer Reddy. Affiliation to GSS Medical College and Hospital, Mysore, Karnataka, and Vinnytsia National Medical University, Ukraine. So, about the sarcoidosis, sarcoidosis is generalized granulomatous multisystem disease with known casein in granuloma. Pathogenesis still remains unclear, and it is also considered as a diagnosis of exclusion. Presentation of sarcoidosis is considered as a rare presentation. It is almost present in 10% of the cases, and getting the cardiac involvement in these cases is rare to rarest. And that too presenting as a multiple intracardial masses, it also very difficult and also adds to a diagnostic difficulty. So we will discuss this in the short presentation about this extremely rare presentations. Hope you will enjoy it. About the patient was 40-year-old female, presented as with palpitation, dyspnea, and lightheadedness. Dyspnea is only present when there is in the presence of palpitation or during the episodes of a palpitation, which is worsened on exertion, but without chest pain and angina. Family and social history: pulmonary sarcoidosis was present in the father and SLE in siblings. So there is there is presence of the autoimmune history in the family, and there is no history of alcohol and smoking abuse noted. Physical examination: patient shows bradycardia of 54 beats per minute and blood pressure of 136/88. And there is no overt signs of heart failure or distant heart sounds are heard. There was presence of the conducting heart sounds, but no distant heart sounds were heard. We did the initial diagnostic workup in the patient. Initially, considering in view of the bradycardia and the palpitation, we did the ECG of the patient, which came as the Mobitz 1 second degree AV block, and which eventually progressed into the severe bradycardia. Then we did the advanced cardiac imaging and biopsies. Cardiac magnetic resonance MRI demonstrated the presence of the two distinct masses within the right atrium, one measuring the 27 into 14 mm along the posterior right atrial wall just superior to the inferior vena cava junction, and another anterior mass measuring 18 into 19 millimeter located inferiorly along the intra-atrial septum. Masses were isotense on T1 to T2 and did not exhibit signal progression on fat saturation. Homogeneous perfusion was noted within the masses along with the delayed gadolinium enhancement consistent with the vascularity and necrosis. Initially, this is raising suspicion of malignancy, which was subsequently ruled out by the whole body CT scan, and patient was then put on the cardiac diet for being scheduled for PET CT. The most sensitive in this case was 18 FDG PET CT. Findings revealed the several foci of the abnormal metabolism in heart in the background of the patchy activity, including at the level of the atriocaval junction, anterior to the descending thoracic aorta, and caudal to the left mediastinum bronchus. Additional focus in the right atrium and additional focus in the space between the two atria were also found, with no evidence of the pleural or pericardial infusion, as we didn't heard distant heart sounds also. A more subtle focus of uptake was also noted in the left ventricular apex. The most prominent foci, two in number, were found in the right atrium, SUV 8.14 and 8.48 respectively, with associated low levels of uptake within the bilateral hilar lymph node station. These are the two masses. Other than that, repeat ECG showed complete heart block with a narrow escape at 33 beats per minute. Patient showing progression of the conduction disease, for which she ended up getting a temporary pacemaker. Bronchoscopy done in view of the avid hilar lymph node. FDG update was inconclusive, and endobronchial lung biopsy showed no granuloma or malignancies. After some time, we did a cardiac MRI or intracardiac ultrasound examination, showed there were the two discrete well-circumscribed echogenic structures in the right atrium. The first structure measured was 1.3 to 1.2 centimeter and was located in the superior aspect of the right atrium, and the second structure measured into 1.2 to 1.4 centimeter and was located inferior to inter-atrial septal region. The patient underwent the two endometrial biopsy, one of which was normal, the other was ICE-guided, which is intracardiac echocardiography, demonstrated a large pedunculated mass arising from the membranous intra-articular septum, extending superiorly, posteriorly into the intra-arterial septum, then emerging posterior direction from the intra-arterial septum, covering the coronary sinus. We'll discuss about this location and the presentation of the patient in the discussion part, and extending to the posterior floor of the right atrium, posterior to cavotrispid isthmus. A second mass arose from the intra-arterial septum, more superiorly towards the superior vena cava, right atrial junction, but this was not as well visualized on eyes compared to other imaging modalities. The latter showed the presence of the atypical spindle cell, which was negative for cell marker, still making it difficult to rule out the possibility of the angiosarcoma, hence requiring the surgical removal of the mass to determine the basic pathology. Intraoperative pathology demonstrated a granuloma on frozen section, as you can see on the screen as well. And the final surgical pathology revealed the nodular extensive myocardial involvement by non-necrotizing granulomatous inflammation suggestive of the sarcoid type of granulomas. Microscopic examination revealed numerous non-caseating granuloma, diffuse fibrosis, asteroid bodies, and giant cells, all consistent with sarcoidosis. These findings were not compatible with lymphoma, angiosarcoma, rheumatoid nodule, giant cell myocarditis, or a foreign body reaction. Concurrently, patient's blood sample was sent to check the level of the ACE, which was increased, which is 28.4, and there was increased level of the soluble IL-12 receptor to 5844 picogram per ml. Differential diagnosis we thought was intracardiac myxoma and lymphoma, which was ruled out by the negative biopsy and the absence of the intracardiac metastasis. Giant cell myocarditis and rheumatoid nodule. There was no history of the relevant family history and clinical finding and negative rheumatological workup. Cardiac amyloidosis, it can also present with delayed gadolinium enhancement, but absence of other features. Angiosarcoma, biopsy showed the presence of the atypical spindle cells, which can also be caused by the inflammatory reaction and the presence of the benign characteristics, which rules out angiosarcoma. Management. After removal of the intracardiac masses operatively, the patient underwent the removal of the temporary pacemaker and insertion of the dual chamber ICD implant to treat the complete heart block that had resulted from the progressive conduction of disease due to sarcoid. The current rhythm being the ventricular pace at 60 to 80 beats per minute. The patient was started on 30 milligram of the methylprednisolone IV daily with eventual tapering. Cholecalciferol 200 to 400 mg for the low vitamin D levels. And an outpatient started on infliximab 5 mg per kg every 8 hourly and methotrexate 7.5 mg weekly. The patient was scheduled for a regular follow-up of 3 months, after which TTE should be done to check the disease progression and clinical remission. Discussion part. The pathophysiology of the conduction disease. It opens a two school of thoughts in our view, that the mass effect nearing the AV node causing the mechanical disruption. As we discussed that there is one mass is nearing the posterior aspect of the intra-atrial septum, which can invade into the AV node and can cause the conduction defects. And other school of thought was the diffuse granulomatous inflammation leads to the multifocal conduction defects, as seen in many inflammatory diseases causing the conduction difficulties. There were also diagnostic challenges, like it mimics malignancies like angiosarcoma and other infiltrative diseases like amyloidosis. But multimodal approach essential for this is cardiac MRI, PET CT, and histopathology. The most sensitive in this case was the 18 FDG PET scan, and there were some management nuances like steroid is often effective, but in severe cases, biological like infliximab are needed. According to some expert consensus recommendation, like Brini et al., diagnostic criteria, there is also gold standard is also 18 FDG PET scan. And the latter demonstrate that a hilar mediastinal lymph nodes can be metabolically active without being enlarged, as seen in this patient. Focal on FDG pattern likely to indicate cardiac sarcoidosis, but can help point towards a diagnosis even when endomyocardial biopsy is negative and late gadolinium enhancement on a cardiac morphology MRI is invariably diagnostic for cardiac sarcoidosis, both of which are seen in this case above. Right. And the treatment by this patient is present in parallel to the general recommendation, which involves corticosteroids being primary pharmacological therapy to delay the natural course of the disease and the fibrosis in this patient. and placement of the ICD also improves the prognosis of this patient and the clinical outcome. While it is true that the steroid treatment can be effective in some cases of cardiac sarcoidosis, but it clearly outlines the rapidly progressive nature in the patient's conduction disease, culminating in complete heart block. Patel et al. Demonstrate in patients with isolated cardiac sarcoidosis less profound effect of the steroids in ameliorating the conduction system manifestation of the disease. This, coupled with the rapidly progressive nature of the disease, conduction work necessitated permanent ICD placement. Certain international consensus recommends us to using methotrexate and TNF alpha blockers, infliximab or adalimumab as we use in this case. But this comes under the second line or the third line treatment of this patient. The first line also always been steroid as the primary or the basic pharmacological treatment of this case. Obi et al. Assert the initiation of the immunosuppressive therapy early in this case of the cardiac sarcoidosis yields a better outcome. As in this patient, the patient is towards a complete recovery, and it is additional. Yeah, it is noteworthy that there are only handful of the rare cases worldwide that discuss in detail how sarcoidosis can usually present as intracardiac tumor and how it needs to be differentiated from the other potential intracardiac masses. Our patient is expected to make a full recovery, as it is also elaborated by the Powell et al. And ultimately, this case underscores the importance of the maintaining high index of suspicion, employing a multimodal diagnostic approach, and tailoring treatment of strategies to individual patient needs the management of the cardiac sarcoidosis. Post-surgical recovery of the symptomatic improvement and residual muscle significantly reduced. Normal cardiac function was maintained. As you can see, the post-op echocardiography of this patient. Follow-up plan of the serial transthoracic echocardiograms to monitor remission. A regular assessment of the inflammatory markers like IL-2 receptors and neopterin, and adjust the immunosuppressive therapy based on the disease activity. Key takeaways: a rare presentation of the cardiac sarcoidosis is presenting as the intracardiac masses is exceedingly rare. Diagnostic essential as multimodal imaging and the histopathology are pivotal for diagnosis. Therapeutic insights like early intervention with steroids and biological is critical to prevent progression. Learning point is cardiac sarcoidosis should be a differential in atypical intracardiac masses. Acknowledgements to Dr. Sachin Gupta for guidance. References at Brini et al., Powell et al., and additional literature from the cardiac oncology at Hertha journals. Thank you.
Bangladesh. I am going to present a topic on which I am working for last 10 years, that is formalin therapy in radiation proctitis. Radiotherapy is an essential treatment modality for pelvic malignancy, such as gynecological, rectal, and prostate cancer. Chronic radiation proctopathy is one of the most bothersome and toxicity of those patients. The incidence is reported as high as 20%. And the common time of presentation of such complication is 8 to 12 months. And most of the present do colonoscopic biopsy, as injured area may not heal and perforation may occur. A colonoscopic biopsy only we do if there is suspicion of malignancy. We treat this patient by gradually. At first, we treat by medical treatment. And if medical treatment fail, then we go for some other ways like formalin therapy, argon plasma coagulation, this. And if all these measures fail, means patient is suffering from severe bleeding per rectum and repeated blood transfusion is required, like 30 bag or 40 bag unit, then we go for operative treatment. The medical treatment we use non-steroid anti-inflammatory agent like sulfasalazine, oral corticosteroid, rectal steroid detention enema, sucral-fed enemas, short-chain fatty acid enema, mesalamine suppository, and formalin therapy I am using last 10 years. And if after formalin therapy no improvement occurs, then I go for APC, means argon plasma coagulation. And last option is operative treatment, that is diversion or excision. At first, radiation proctitis, this conception comes from the treatment of radiation cystitis by formalin application. From this, it is shifted to formalin application for radiation proctitis. Formalin acts only on the superficial mucosa, which results in rapid coagulation of the blood vessels and decrease the bleeding. Chronic radiation-induced proctitis leads to recurrent or massive hemorrhage, which may necessitate hospitalization and may require repeated blood transfusion. I am working in colorectal surgery since 2014. At that time, I received a case in outpatient department suffering from bleeding per rectum. And that patient, there was a colonoscopy when the patient came to me and was diagnosed a case of radiation proctitis. Then I try to give some medication, but the patient didn't improve. Then again, I go through the books and I saw that there is formalin application. Formalin application, this is recommended in the ACRS, American Society of Colorectal Surgery textbook, second edition. I saw it, that is formalin application. And I discussed this with my teacher in 2014 and also with the patient that I want to go to apply 4% formalin as it is recommended by our textbook. And the patient agreed. And our teacher also agreed. Then I proceed to apply 150 ml 4% formalin via a urinary catheter. I passed it through the rectum and push 150 ml 4% formalin and keep it for 3 minutes. At that time, I was actually very much anxious because I know that formalin is very, it make harm to the patient, I thought. But the patient recovered well, improved from bleeding per rectum and without any complication. Then that made me the confidence within me that 4% formalin can be applied to the rectum. Since then, I have been using 4% formalin for the treatment of radiation proctitis, applying it via colonoscopy and leaving it in place for 3 minutes. 2019, I presented the topic formalin therapy in radiation proctitis in our only national institute, the largest national institute of Bangladesh, NICRIs, and there I was rewarded. It is this picture is on. Then how I collect 4% formalin. Actually, the formalin which is available as 40% formaldehyde. 40% formaldehyde is known as 100% formalin. So 40% formaldehyde which I got, that is the 100% formalin, and I want to make it 4% formalin. So in a big funnel, I give 960 ml of water and 40 ml 4% for 40 ml 40% formaldehyde, means 100% formaldehyde. So 960 ml water and 40% formalin, 40 ml formalin, total 1000 ml. Then to make it neutral as buffered solution, I use this sodium hydrogen 6.5 gram and this the 0.4 gram this solution hydrogen. So it 6.4 gram this solution sodium hydrogen and dihydrogen 0.4 gram. So it become the pH become 7, means it becomes a neutral solution. Then measure it by a pH meter, and the result is pH 7. So it is become 4% formalin with buffered solution, means neutral pH. Then I apply by colonoscope scope. And usually the lower and mid rectum are most commonly affected area. Lower and mid rectum. Then in that area, I apply 150 ml of 4% formalin by the scoop. 150 ml. And ask the patient already gave injection ketorolac and midazolam. So the patient to decrease the pain, because when formalin becomes in lower area of rectum and in contact with anal canal, patient become very painful. It becomes very painful to the patient. So I give ketorolac injection and midazolam injection. Then request the patient to hold it for 3 minutes. In my research, I deal with 10 patients who have been suffering from bleeding per rectum following pelvic radiotherapy. The inclusion criteria was bleeding per rectum following pelvic radiotherapy after failed medical treatment, and rectum is free of malignancy. And exclusion criteria was patients with large ulcer, mucosal necrosis, or the variables were the primary neoplasm, radiotherapy type, onset of bleeding after radiotherapy, frequency of blood transfusion, number of formalin application sessions, complications after formalin therapy, improvement after formalin therapy. All patients underwent colonoscopy evaluation prior to formalin irrigation. Complete glycol. Patient received intravenous sedation with propofol and or position on the left lateral decubitus position. 150 ml of 4% formalin was administered via colonoscope in the affected area of rectum. Air was aspirated using the colonoscope, after which the scoop was carefully withdrawn. The formalin was retained for 3 minutes before being suctioned with the colonoscope. A perineal wash was then performed using normal saline. Patients were allowed to return home after 1 hour. Insufficient improvement in rectal bleeding. If there is insufficient improvement, means the there was bleeding still continued but less amount, then I apply second session of formalin in after 1 month. And the result is here. Most were the female patients were suffering from cervical cancer, and they got the external beam or brachytherapy.
Dr. Edison, we can't hear you.
Hello?
Oh, yes, now we are audible.
Yeah. Can you hear me? Okay, I'm going to proceed.
Yes, we can.
Yeah. All patients had been treated. Sorry for interruption. All patients had been treated conservatively for hemorrhage. Excuse me, can you hear me? Hello?
Yes, doctor, we can hear you.
Yeah. All patients had been treated conservatively for hemorrhage after their radiotherapy, but due to lack of improvement, they were subsequently referred for formalin therapy. So formalin therapy, I treat this patient as second-line treatment, in whose those patients where the medical treatment not applied. The average duration of bleeding after completing radiotherapy was 8.6 months with a range from 15 days to 20 months. Average requirements of blood transfusion was 6.9 units. 4 patients improved after single formalin therapy. 6 patients need formalin therapy for 2 sessions. No patient suffered from any significant complications. And complete improvement of bleeding in 4 patients, partial improvement in 5 patients, and 1 patient had no improvement and later required a diversion colostomy. In our study, we found 4% formalin application to be safe, moderately effective, and a cheap alternative with no significant complications in treating radiation-induced hemorrhagic proctitis. We can recommend 4% formalin application as second-line treatment for radiation-induced hemorrhagic proctitis when medical management fails. Actually, the radiation proctitis patients who are suffering, most of the patients are becoming free from cancer, but they are suffering from radiation proctitis in such a troublesome condition. It's a miserable condition. In like one patient may require 30 units, 40 units blood transfusion. And though radiation proctitis has a climax of the disease, like fever, viral fever, where there is climax 3 to 4 days, then again the fever become reduced. So radiation proctitis has a climax to the patient of affection of the disease. About 6 to 12 months the climax period. After which it is gradually decreased naturally. But during this period, to support the patient, it's very difficult and it becomes very cumbersome to the patient and the family of the patient. I am applying 4% formalin. Though this study was 3 years ago, in this last 3 years, I applied 4% formalin, more patients, and I got the result. The result is about the success rate is 50%. As formalin is very cheap agent, and it is less side effects. And I also applied APC, but I think that formalin is more effective than argon plasma coagulation in treating 4% radiation proctitis. Thank you. Hello, have you any question? You can ask me.
Thanks, Dr. Ayusin, for your wonderful presentation. So, any questions for
national webinar on oncology research and treatment. And for today's discussion, my topic is cutting edge therapies and molecular drivers in pediatric leukemia and bridging innovation and care. So let's start this. So first, we have to know what is pediatric leukemia. So primarily, it is due to excessive growth of your white blood cells, especially in children, and it is majorly categorized into two, like AML and ALL, that is acute lymphoblastic leukemia and acute myeloid leukemia. So it's the most common childhood cancer. 30% of pediatric malignancies involving this. So as we talk about epidemiology, the global incidence of pediatric leukemia is approximately 4.8 cases per 1 million children between the age of 0 to 14. So high income region report better survival outcomes due to advancement in therapies, while resource constrained areas face disproportionate burdens. Ethnic variation also exists, with white children experiencing higher ALL rates as compared to Asian and African children. So this slide is basically focusing on the different geographical and epidemiological variation in the incidence and prevalence of pediatric leukemia. As far as we are concerned regarding the risk factor of pediatric leukemia, so it may be many risk factor, but mainly it's due to genetic predisposition involving chromosomal abnormalities, which are at various level and at various stages. We'll discuss it on other slides, and some environmental exposure as well, such as ionizing radiations. So this is a flow chart you can see here. So it is showing treatment modalities for pediatric leukemia, and that's the main title of our presentation. So we are well aware of chemotherapy and like radiotherapy. And there are some other advanced therapies, including immunotherapy and some targeted therapy. So for the in the past time, only chemo, bone marrow transplantation, and some drugs related to immunotherapies were considered as a treatment for pediatric leukemia. But for now, with the passage of time, uh, different advancement have been developed in this field. So here you can see, as we talk about the chemotherapy, there are three phases: induction phases, consolidation phases, and maintenance phases. For induction phases, we give daunorubicin, vincristine, and prednisolone. And for consolidation phase, we give cyclophosphamide, cytarabine, and captopril. Then for maintenance phase, we give methotrexate, vincristine, and mercaptopurine. For immunotherapy, we have categorized the drugs based on its function at the molecular or cell level mechanism, like CAR T cell therapy, immune check inhibitors, and some new emerging immunotherapy we will discuss in detail, bispecific antibodies and natural and neutrophil killer cells therapy. So for CAR T cell therapy, it is T cell legulicil, and for immunocheckpoint inhibitor, famous one is pembrolizumab. And for targeted therapy, we have some monoclonal antibodies. We also use that in other cancers or autoimmune disease as well. Famous one is rituximab, and some small molecule inhibitor imatinib, especially we use in the patient of CML, and other targeted therapy, dasatinib and carfilzomib. For radiation, we give like multiple sessions of radiotherapy to the patients who are not responding to like chemotherapy or immunotherapy, or like who is not a candidate of chemo will go toward the radiotherapy if he can afford the side effects of radiotherapy. So we can go for either cranial radiation or total body radiation or involved field radiation. For stem cell transplantation, we will have two options, either for allogenic transplant or autologous transplant. So what are the advancement in therapies? So recent breakthroughs in genomic analysis has identified over 30 ALL subtypes based on chromosomal rearrangement and mutation. As we discussed previously, chromosomal rearrangement is the most important risk factor to cause pediatric leukemia. So over 30 plus mutations have been identified in especially in ALL. And there are some example as well. As we talk about, there is a mutation that is ETV6 and RUNX1 rearrange ALL. So it represents 20% of the pediatric ALL cases. And the good thing is that it has a favorable outcome and good prognosis. And the other famous one mutation with associated with ALL, that is BCR ABL1 positive ALL. It is linked with aggressive disease. Okay, so outcome have improved with tyrosine kinase inhibitor, as we discussed previously, metinib, distatinib, and this mutation, as we are discussing it, BCR-ABL1 positive ALL, it is defined by fewer than 44 chromosome associated with TP3 mutation, that is P53 mutation, and it is requiring more intensive and aggressive treatment, and it has poor prognosis. So here we discuss like two major mutation that we see in the cases of ALS. First one is having like favorable outcome, favorable prognosis, otherwise than having poor prognosis. As we talk about the chemotherapy in the previous slide, it is involving like multi-phase regime, as we discussed previously, and it is the main cornerstone and the basis of the treatment of pediatric leukemia. And in the previous era, bone marrow transplant is also considered as a curative approach, especially for high risk cases who are not responding to chemo. But for now, we are moved toward, or we are shifted towards immunotherapy that is majorly considering monoclonal antibodies such as blinatumomab, or CAR T cell therapy such as TSAG and legleucel. So we discussed these two major mutation like BCR-ABL1, that is having poor prognosis, requires aggressive treatment. ETV6 next one, it has favorable outcome. It requires not so much aggressive treatment. For AML, major mutations are FLT3 ITD. For that, we start FLT inhibitor. Another famous mutation is NPM1. So these are due to epigenetic changing and aberrant signaling pathway, eventually production of either like favorable or like poor prognosis of ALL. So as we discussed, there had been some innovation from the past up to the day now, in especially in immunotherapy. So monoclonal antibodies, such as blinatumomab and inotuzumab ozogamicin. These are the major famous monoclonal antibodies that actually target your lymphocyte, especially blinatumomab at the level of CD19 and other one at the level of CD22. And CAR T cell therapy we discussed. Usually, the famous one is TSAG and legleucel, and it is used or reserved for the refractory ALL that is not responded to other immunotherapy agents such as monoclonal antibodies. Here you can see like a survival and relapse rates in pediatric ALL. So as we discussed previously with one major example with epigenetic mutation of ALL and AML, one was having with higher prognosis and one was with poor prognosis. So here you can see in this graph, this one survival and this red one is relapse rate. Okay, so if there is low risk ALL, as we discussed, so it will have more survival and the chances of relapse would be less, like only 10%. While if there is a kind of high risk ALL, it will have survival up to moderate level, and there is some extent of relapse rate as well. You can see here 30% relapse rate and 70% survival rate. And if it is relapsed ALL or refractory ALL that we discussed previously, so it will more chances of relapse or recurrence, and it will have poor prognosis with only 40% survival. So this is how different types of pediatric leukemia are associated with different percentages or proportions of survival and relapse rates. So up to now we have discussed some kind of basic therapies, then some advancement in therapies with some example with some kinds of mutations in the pediatric ALL with their relapse rate and survival rates. So now we have to start the therapy. And what are the challenges in starting that are resistant to therapies? Okay, and treatment related toxicity. And one of the big challenges, graft versus host disease. And sometimes we have to consider the environmental and socioeconomic factor and price or cost of the product. So, and their accessibility to the remote areas or to the area where patients are majorly available. Okay, so these are some kind of challenges. So basically, accessibility, high cost therapies are out of reach for many low income families. So it is one of the most common challenges in providing efficient and effective immunomodulator or immunotherapeutic agent in treatment of pediatric leukemia. And sometimes due to giving these agents, some toxicities also occurred, and there are some global disparities as well, for which we have to go for collaborative frameworks that are essential to bring equitable care to advance or to the underserved regions. So we discussed this previously, outcomes and survivorship like ALL greater than 90% in high income countries, and AML challenges persist due to heterogeneity. And long-term effects, secondary malignancies, organ dysfunctions, and neurocognitive issues. So these are some kind of side effects as well. So it is a summary of some major latest studies that done on the advancement in treatment of pediatric leukemia. So here you can see there are some uh, original studies, some review article. They have basically discussed different treatment strategies in the evolving era of the pediatric leukemia. So these are the link you can study in deep. And what are the future directions? So personalized medicine. So whenever it is involving multidisciplinary approach or we there are some kind of challenges, especially as we discussed previously, a challenge of accessibility, challenge of cost, and challenge of some drugs are not working, some are having a severe toxicity. So in this kind of situation, we have to go for personalized medicine or individualized medicine. In this, we tailor or taper the treatment according to the molecular profile, not only according to the molecular profile of the patient, but also considering other parameters as well. we discussed it. So coming towards the conclusion. So to conclude, while pediatric leukemia treatment has been a remarkable advancement, addressing the remaining challenges will require sustained innovation and collaboration. By bridging science with care, we can improve survival and enhance the quality of life for affected children and their family. So this was all about a brief discussion regarding the different treatment approaches towards pediatric leukemia, and brief discussion regarding what advancement has been done. Thank you so much. I really welcome your question. If you have any question, let me know. Thank you so much.
And my presentation about cervical cancer metastasis to the vertebra. When discussing this issue, it is important to note this patient can be divided into two groups. The first group includes those with true bone metastasis, while the second group comprises patients with metastasis in displaced lymph nodes, infiltration the vertebra. The second category tends to have a much better prognosis, likely due to the less aggressive nature of the tumor, which remains confined to regional lymph nodes. This later group represents a target population for extensive surgical intervention. Data on patients with solitary spine metastasis of cervical cancer are limited to isolate case reports and look comprehensive analysis. On average, this survival rate for this population is only 8.5 months, which is alarmingly low and warrants our special attention. Our patient is a young woman born in 1983. Let us review her diagnosis and medical history. Squamous cell carcinoma of the cervical T1B and 1M0 stage 3B. Status after preoperative radiotherapy in September 2018. Status after surgical treatment in September 2018, status after 3 courses of chemotherapy with taxotere and carboplatin, progressive in January 2019, metastasis to left iliac lymph nodes, status after intestinal and external radiotherapy, status after removal of metastatic lymph node in left iliac area with aortavenous prosthesis, reconstruction of the common iliac artery. Progression in April 2019, metastasis in the left iliac group lymph node with conglomerate formation and invasion into L5 vertebra. Status after 3 courses of chemotherapy, no improvement during treatment. Status after 18 courses of immunotherapy, partial tumor regression and remission according to PET-CT, data from January 2021. Given the solitary nature of tumor and the good therapeutic effect of immunotherapy and the preserved metabolic activity according to PET-CT, risk of further progression, the decided was made to proceed with the surgical stage of treatment. The preoperative examination indicate the following extent of disease. The metastatic tumor conglomerate is located in the left iliac region with destruction of the 5th lumbar vertebra, invasion into the left ureter, cause obstruction, and the descending colon, and dense adhesion to the aortic bifurcation. Here you can see video based based on CT and MRI findings, we can more clearly observe the extent of the tumor, including ureteral obstruction with the development of hydronephrosis and aortic involvement. So, operation en-bloc resection of a retroperitoneal metastatic tumor, left helical ectomy with a staplet anastomosis, left nephrectomy with ureter removal, resection of the aortic bifurcation with prosthesis reconstruction, L5 vertebral spondylectomy, vertebral body replacement with a mesh type endoprothesis, posterior lumbosacral stabilization using the Expedium Medtronic system. Stage 1, this posterior approach and the L5 vertebra, tonectomy of the fourth and fifth lumbal vertebra with lumbosacral fixation using screws. And anterior approach, stage 1, laparotomy, left nephrectomy with ureter removal, left gemicolectomy, dissection of the metastatic conglomerate, resection of the aortic bifurcation with reconstruction, spondylectomy of the fifth lumbal vertebra with anterior replacement and combined stabilization. The surgery lasted 8-9 hours with the blood loss of 500 milliliters. So here we can see the removed organ complex in en-bloc, and the resection margin are free of tumor growth with pathomorphological and postoperative radiology examination. And key postoperative CT allows for the assessment of the stabilizing structure and aortic bifurcation prosthesis. So the patient was mobilized on the third day after surgery. The postoperative period proceed without complication. Here is the patient's condition and activity 2 weeks later, at the time of discharge from the hospital. So the patient 1.5 months after surgery, the patient is walking with the support of a cane. This is moderate process of the left femoral nerve. And today, 44 months have passed since our surgery. The patient is under dynamic observation without signs of progression. Adjuvant therapy was not administered. In conclusion, I would like to say that we have already encountered 7 such clinical cases in our practice. This is truly a challenging category of young patient with whom extensive multi-organ resection clearly justified in cases of solitary metastasis to the vertebra. We would like to learn from the experience of other doctors and conduct a joint analysis on a large number of these kind of cases. Thank you very much for your attention. So I'm finished. If you have some question, welcome.
Then this work was done along with Professor Punita Velan from VIT Chennai. So the agenda for the next 20 minutes is going to be a quick introduction to machine learning. And specifically in the machine learning, I'm going to talk about the clustering and then into the KMeans++, based on which I have done my research. On the other hand, I'm going to talk about the radiotherapy, which is used for treating the cancer patients, including the breast cancer patients. And what is it about the daily QA that is required in the external beam therapy? And the device that I have used to do this calculation, that is the PTW's quick check webline. And then I'm going to club the KMeans++ with this daily QA measurements, and we will see what we are getting. So machine learning is the buzzword around the global here. So this is also a part of the artificial intelligence group. So first, let's see what a machine learning is. So this is, though it is machine, it's not actually a machine, it's a software which reads or which learns from the data that is being input to it, like how humans understand things from the data that is they see and hear. Okay, so here what we see is, for example, if there is a cat and a dog, you train the machine learning in such a way that it should be able to identify the cat and the dog. Not only that, the same cat, if it is lying down, sleeping or jumping, like a human can easily identify that. But what we are going to do is we will make the machine also to understand that even if it is lying down or if it is in a different posture, a cat is a cat. And it should be able to identify that cat without any additional programming. So that's what basically a machine learning is. And as I just told, that machine learning is a part of a subset of an artificial intelligence. Okay, so and the so-called deep learning, which is the neural network, is again another subset of the machine learning. So this is basically the structure of what the artificial intelligence or the machine learning or the deep learning is considered. Now, since our topic is on the machine learning, so let's first see what are the different classifications of machine learning is. So machine learning was, I should say, it was in picture right from the 1960s or so. And at that time, they had only two types of applications, like supervised and unsupervised. And now you can see that we have 4 different classifications. And down the years, I'm sure this will be further enhanced into another multiple classifications. So as of this very moment, we can say that machine learning is classified into first a supervised. And as the name indicates, you will see that supervised means you label the data and then you feed it into the program. So you tell, this is the picture of the cat, this is the picture of the dog, this is the picture of the house, like that, and you feed it to the machine learning algorithm, so that after that, whenever you give any other picture, it is able to identify and classify that. That is supervised. Semi-supervised is, supposing we are going to have a large number of data, then it's not possible to label each and every one of them. So in that case, what we do is we partly label them and the remaining we allow the machine itself to understand. Unsupervised, and as the name indicates, here there is no human intervention at all. We are just directly going to feed in the data and we are going to ask the machine learning algorithm to classify or do whatever it wants with that. Then comes the reinforcement algorithm. That is an advanced algorithm in the machine learning. So here what happens is, after it does its first work, a reward or a penalty point is given, whether the work is accomplished correctly or not. And this iteration process goes on till finally, when the total rewards is more, then we say that the algorithm has completed its task. So that is the reinforcement algorithm. In our process, we are going to concentrate on the unsupervised machine learning algorithm. So here I'm going to give in the data from the radiotherapy equipment, and I'm going to ask it to classify. So unsupervised means basically, if you see, clustering technique is the fundamental of the unsupervised machine learning algorithm. So from the name itself, you can understand that clustering means it's grouping the data. And how am I going to group the data? It's depending on a particular pattern or a similarity. Now, when I say grouping, it can be done in multiple ways. There are lots of different ways, and of which there are some 4 techniques, like centroid-based, density-based, connectivity-based, and distribution-based. And of course, I'm going to concentrate on the centroid-based. Centroid means it's a center of any geometrical shape. Okay, so in this case also, I'm going to take this kind of a centroid-based grouping. And here, how you will know whether they are grouping is, since it is going to be geometry kind of stuff, we will check every data point and see how close they are to the centroid. That is how this is done. So how are you going to check that distance? I'm going to use the normal Euclidean distance. That is the distance formula which we use in the daily geometry. Or I can use cosine similarity. That's another way of giving it, like we call it as a norms and Manhattan distances. So these are the different types of distances that we can use to check if a point is closer to the centroid or not. And based on that, we will be grouping it. Okay, having known about unsupervised, having known about clustering, let's now go deeper into K-means plus plus, which is the basis of my whole work. So in K-means plus plus, that is also a clustering, the first thing that we will have to do is define the number of clusters. So you can ask, because you said it's unsupervised and everything the machine is going to understand by itself, then why do we need to give it? So this, well, it's a kind of a drawback that with K-means plus plus, you have to give the total number of clusters before it starts to work. But it's not that difficult a task. Shortly, I will show you how easy it is to determine what is the cluster for that particular data which you are handling. So let me take this as an example. I'm just giving you some group of data sets, and I want to group them into 3 different clusters. That's the idea. Now, the first step in this is, of course, I define what is the number of clusters I need. And the second thing is I'm going to initialize one of the data points itself as a centroid. What does that mean? See, for example, I have now had this 3 different colors. I'm just going to have one, let me just add a pointer. So you can see that I have this blue color. This is one group, and I have a yellow color. That's going to be another group, and I'm going to have another as a purple, which is the third group. Now, the way I choose these 3 clusters, or rather the way the program chooses it, one of the data point is chosen as the first cluster, and the second cluster, it chooses one to be far away from the first cluster, and the third one is going to be still farther away from both the 1 and 2 clusters. And then what it does is, it will calculate the distance for every point. If the distance for this particular point to this cluster is calculated, and the distance to this cluster and the distance to the other cluster. And obviously, you will know now that this cluster is closer to the blue one. So naturally, it will be part of the blue cluster. So similarly, every data point is measured, the distance between that with the center, and then the grouping is done. Okay, so whichever falls closer to that centroid is done. So in this example, you can see that these are the blue clusters, these are the yellow, and these are the purple. Okay, what is the next step then? Now, just to go back to the previous slide, as I told you, initially this was the centroid, but now I have this as a geometrical shape of the blue. So naturally, this is not going to be the centroid. I have to move the centroid somewhere here to the center of this geometrical picture. So that's the next step. I am now going to move the centroid, or rather the centroid is actually shifted to the center of that group. Now again, the second process starts. Let's start from the first. So this data point is now checked whether it is closer to this centroid or this centroid or this centroid. So every data point is now checked again and again as a second iteration process. And if there is anything required to change, let me say, for example, this blue is more closer to yellow, then this blue would turn into yellow and it will form this cluster. So this is how the clusters are done. The iteration goes on happening until no more movement in the data points. So that is the K-means plus plus. Okay, so having known about this K-means plus plus, let's now jump into the radiation therapy and see how we are going to use this K-means plus plus there. Giving a quick intro to the radiotherapy. Yes, radiation therapy is one of the important mode of cancer treatment for all types of cancers. And of that, we have 2 categories. One is the external beam, where the radiation comes from outside, and another is the brachytherapy, where the radiation is allowed to irradiate within the patient. Now, in this topic, we are more bothered about the external beam radiotherapy, and that is being used with a linear accelerator. Now, with the linear accelerator, you will have to treat the patient for at least minimum of 20 to 25 fractions, which means the patient should have the same quality of beam every day for all the 25 days. If, for example, the parameters are changed, we have some parameters which I will show you shortly. So that means then the treatment is not as we actually planned for. Hence, it is important, very, very important that every day the beam parameter is checked for some kind of a consistency. So for which we have something called as a daily QA. This is done in all the places where they have the linear accelerator, and it is also mandatory to check with this. So there are many devices available. Vendors have given their SNC, Sun Nuclear has their daily QA device, and IBA, that's another vendor who has this My QA daily device, and the PTW, which has a quick check webline. This is the device I have used for my research work. So let's first see what is this quick check webline. Yes, you can see this is a very small device, easy to carry, and you can keep it on the linac pouch and you can irradiate it. This is wireless, and when the irradiation happens, it will determine the CAX, that is the central axis dose, flatness, and as the name indicates how flat the beam is. Symmetry is how symmetry the beam is between the central axis on either sides. And the beam quality is what type of energy we are irradiating. Of course, it can also measure the wedge angle, which is not of interest for us here in this case. So what happens is on the day one, when I know my linac is performing very well, and it is that data which I have taken to do the treatment planning, on the same day, I will keep this device on the couch and I will irradiate the beam. Once the irradiation is done, I will set it as the base. So this is very important. I will set it as a base, and subsequently on all other days, the regular measurement happens. Now, when I set this as a base, I have to give it a limit. Okay. So from this baseline, usually people give 2% or 3% as the limit. Say in this example, you can say 100 is a target, and whether in this case it is 2% they have given, even for the beam quality. So when the subsequent radiation is done and this device shows it on the panel, if it falls within this 2%, yes, we say that the data is fine and we can go ahead with the regular treatment. Whereas if there is any deviation, then it needs to be addressed to before going further. This is how the
faster and more accurate. We use the superpowered AI, kind of like ChatGPT, to make this happen. These AIs are amazing and understanding lots of information, including all the complex stuff about genes and disease. Our system uses this AI to analyze genetic variant annotation much faster and more accurate. To train our AI, we gave it massive amount of data, years of research papers on cancer and genetics. We used the specific keywords and focused on our oncology journals from 2005 to 2024. That's a lot of reading. This data was key to teaching the AI. We started with a pre-trained AI, and then we fine-tuned it with our spatial data set. It's like taking a smart dog and training it to be medical expert. This two-step process is really efficient. We tested the AI rigorously to make sure it's reliable. We checked its answer against those of expert doctors using a well-known measure called the Bert score, and the result was incredible. Our AI was significantly more accurate and much faster than before. And AI system is pretty straightforward. It takes the genetic test data, searches relevant medical database like Glimvar or OMIM, searches through everything and gives clear and easy to understand interpretation. It can even help generate a report for doctors. We are still working on it, and we are making it even better at handling complex genetic changes and working on making it user-friendly for doctors. Our goal is to give doctors everywhere a much better tool to analyze genetic information. So, in conclusion, our AI is revolutionizing genetic annotation program and making it much faster, more accurate, and ultimately leading to better care for patients. Thank you for listening. I'm happy to take any questions.
We have previously shown that CREC4A4, a member of C-type lectin receptors with an item in its cytoplasmic portion, suppressed the PRR-mediated activation of murine CD8 alpha negative CDC2 based on self-interaction through EPS glycan within the CRD, which constitutively delivers inhibitory signaling via item. Furthermore, we have revealed that CREC4A4 negatively controls inflammation, antigen-specific T-cell responses, and autoimmune disorders, as well as microbial infection through the regulation of the function of CDC2. Thus, CREC4A4 regulates the function of CD8 alpha negative CDC2 for the control of the magnitude and quality of immune response. Immune checkpoints are regulators of immune activation to play key roles in maintaining immune homeostasis and preventing autoimmunity. In cancer, immune checkpoint mechanisms are often activated to suppress the immune surveillance mechanisms, leading to immune escape of tumor. CREC4A4 and PD1 expressed on T cells function as immune checkpoint molecules, blocking monoclonal antibody against CTLA4 and PD1 system are currently used as immune checkpoint inhibitors for tumor immunotherapy in the clinical settings. Although ICIs can provide the dramatic curative effect on several types of tumors, it has been pointed out their non-responsiveness and resistance acquisition in many types of tumors. It fears that the use of ICIs causes immune-related adverse effect, which is induced by activation of immune response to tumors as well as self. Thus, issues to be resolved contain conquests of non-responsiveness and resistance acquisition in tumors, as well as the reduction of IRAEs in the use of ICIs. To establish an innovative tumor immunotherapy, it's urgent to perform the research and development of drug discovery targeting novel immune checkpoint molecules. The pathway for the interaction between co-inhibitory receptors expressed on T cells and their counter ligands expressed on other cell types that acting on T cell function has been appreciated as target of immune checkpoint blockade. However, it remains unclear how blockade of the intrinsic regulatory molecules expressed on TCs that deliver inhibitory signaling affect tumor progression through the control of their function. In this project, we try to identify mouse CREC4A4 and its functional ortholog, human CREC4A, as novel immune checkpoint molecules expressed on DCs that negatively control anti-tumor immunity, and to address the role for the immune suppression during the tumor progression. Furthermore, we will develop tumor immunotherapy with antagonistic monoclonal antibody targeting human CREC4A. We first addressed the impact of the deficiency of CREC4A4 on the progression of tumor using B16 OVA melanoma cells. As shown here, deficiency of CREC4A4 significantly reduced tumor progression. Furthermore, depletion of CD4 positive suppressive immune cells including CD4 positive, FOXP3 positive regulatory T cells, and MDSCs, inhibited tumor progression, while depletion of CD8 positive T cells enhanced tumor progression under CREC4A deficiency. Collectively, CREC4A4 acts as a novel immune checkpoint molecule to enhance tumor progression. To address the influence of the deficiency of CREC4A4 on tumor antigen-specific priming of T cells, we adaptive transferred E-fluor-labeled OT2 CD4 positive T cells or OT1 CD8 positive T cells into B16 OVA-bearing mice and analyzed their division in spleen and tumor-draining lymph node. Whereas tumor-bearing wild-type mice exhibited a more potent antigen-specific division of OT1 CD8 positive T cells than OT2 CD4 positive T cells in tumor-draining lymph node. Their apparent responses were not detected in spleen. On the other hand, tumor-bearing CREC4A4 knockout mice displayed more potent their antigen-specific divisions in tumor-draining lymph nodes than tumor-bearing wild-type mice. Therefore, CREC4A4 acts as a novel immune checkpoint molecule to inhibit tumor antigen-specific priming of T cells in tumor-draining lymph node. We next examine the influence of the deficiency of CREC4A4 on the features in the TME. Tumor-bearing CREC4A4 knockout mice showed lower frequencies of GR1 positive, F080 positive MDSCs and GR1 positive, F080 negative MDSCs in spleen than tumor-bearing wild-type mice. When compared with tumor-bearing wild-type mice, tumor-bearing CREC4A4 knockout mice exhibited the enhanced infiltrations of CDCs, PDCs, NK cells, CD4 positive T cells, and CD8 positive T cells in tumor tissues, and reduced accumulation of GR1 positive, F080 positive MDSCs, and GR1 positive, F080 negative MDSCs. On the other hand, tumor tissues obtained from CREC4A4 knockout mice showed lower transcriptional expressions of IL-10, TGF-beta, IDO, VEGF, alginase, INOS, and MPGES than those obtained from wild-type mice. Taken together, CREC4A4 acts as a novel immune checkpoint molecule to alter the immunosuppressive features in the TME. We next examine the influence of the deficiency of CREC4A4 on the activation status of splenic CDCs and tumor-infiltrating CDCs under tumor-bearing conditions. Tumor progression reduced the expression levels of MSC1, CD40, CD80, CD86, B7H1, and B7H2 in splenic CD8 alpha negative CDCs in wild-type mice. In contrast, the deficiency of CREC4A4 not only enhanced the expression levels of MSC1, CD40, CD80, CD86, B7H1, and B7H2 in splenic CD8 alpha negative CDCs, but also potentiated their ability to produce cytokines even under tumor-bearing conditions. On the other hand, the deficiency of CREC4A4 enhanced expression levels of MHC1, MSC2, CD80, CD86, and B7H1, and reduced expression levels of B7H2 and B7DC in tumor-infiltrating CDCs. Collectively, CREC4A4 acts as a novel immune checkpoint molecule to regulate the activation status of CDCs in spleen and tumor tissue. We also examined the influence of the deficiency of CLEC4A4 on the activation status of CDCs in tumor-draining lymph node under tumor-bearing conditions. Tumor progression reduced the expression levels of MSC1, MSC2, CD40, CD86, CD11C, and B7DC, while it induced the high expression level of CLEC4A4 and B7H1 in resident CDCs in tumor-draining lymph node in wild-type mice. In contrast, the deficiency of CLEC4A4 retained the expression levels of MSC and costimulatory co-inhibitory molecules in resident CDCs in tumor-draining lymph node, and their ability to produce cytokine even under tumor-bearing conditions. Collectively, CLEC4A4 acts as a novel immune checkpoint molecule to regulate the activation status of CDCs in tumor-draining lymph node. We next examine the influence of the deficiency of CLEC4A4 on the activation status of splenic T cells. The deficiency of CLEC4A4 increased the fractions of CD4 positive effector memory T cells and CD8 positive effector memory T cells in spleen under tumor-bearing conditions. On the other hand, tumor-bearing CLEC4A4 knockout mice had similar proportions of MSC1 OVA peptide pentamer positive CTLs and CD4 positive FOXP3 positive regulatory T cells in spleen to tumor-bearing wild-type mice. Thus, CLEC4A4 acts as a novel immune checkpoint molecule to inhibit the generation of effector T cells in spleen. We also examine the influence of the deficiency of CLEC4A4 on the activation status of T cells in tumor-draining lymph node. The deficiency of CLEC4A4 increased the fractions of CD4 positive effector memory T cells and CD8 positive effector memory T cells in tumor-draining lymph node under tumor-bearing conditions, indicating that CLEC4A4 acts as a novel immune checkpoint molecule to inhibit the generation of effector T cells in tumor-draining lymph node. Furthermore, the deficiency of CLEC4A4 not only increased the proportions of MSC1 OVA pentamer positive CTLs, but also reduced the frequency of CD4 positive FOXP3 positive regulatory T cells in tumor-draining lymph node. Collectively, CLEC4A4 acts as a novel immune checkpoint molecule to inhibit or enhance the generation of tumor antigen-specific CTLs or CD4 positive FOXP3 positive regulatory T cells in tumor-draining lymph node. We also examine the influence of the deficiency of CLEC4A4 on the activation status of TILs. The deficiency of CLEC4A4 not only increased the fractions of CD4 positive effector memory T cells and CD8 positive effector memory T cells in tumor tissues, but also led to their reduced expression of PD1, TIM3, LAG3. Furthermore, the deficiency of CLEC4A4 enhanced the proportion of interferon gamma producing MSC1 OVA pentamer positive CTLs in tumor tissues. Thus, CLEC4A4 acts as a novel immune checkpoint molecule to enhance the expression of immune checkpoint molecules on TILs and inhibits the infiltration of tumor antigen-specific CTLs in tumor tissues. On the other hand, the deficiency of CLEC4A4 reduced the proportion of CD4 positive, FOXP3 positive, ROR gamma T positive regulatory T cells in tumor tissues. Thus, CREC4A4 acts as a novel immune checkpoint molecule to enhance the infiltration of CD4 positive, FOXP3 positive, ROR gamma T positive regulatory T cells in tumor tissues. Having demonstrated that human CREC4A is functional ortholog of mouse CREC4A4, we generated antagonistic monoclonal antibody to human CREC4A. To prove the utility of antagonistic anti-human CREC4A monoclonal antibody for the protection against tumor development, we created human CREC4A transgenic mice that express human CREC4A under the control of the murine-2 promoter. As shown here, human CREC4A is highly expressed on murine DC subset in human CREC4A transgenic mice. We first examined the protective effect of antagonistic anti-human CREC4A monoclonal antibody on tumor progression in human CREC4A transgenic mice. As shown here, several clones of antagonistic anti-human CREC4A monoclonal antibody, including A7071, B23.1, and B71.3, significantly inhibited the development of the established tumor. Thus, monotherapy with antagonistic anti-CREC4A monoclonal antibody displays a therapeutic effect against the progression of poor immunogenic tumor. Similarly, antagonistic anti-CREC4A monoclonal antibody or anti-PD-1 neutralizing monoclonal antibody exhibited a similar potent suppression of the growth of MC38 colon adenocarcinoma cells, and their combination led to almost complete inhibition of their growth. Therefore, monotherapy with antagonistic anti-human CREC4A monoclonal antibody displays a similar anti-tumor effect to anti-PD-1 neutralizing monoclonal antibody against the progression of immunogenic tumor, while their combinational therapy exerts a synergistic anti-tumor effect. We next compared the anti-tumor effect of antagonistic anti-human CREC4A monoclonal antibody and anti-PD-1 neutralizing monoclonal antibody against poor immunogenic tumor progression in human CREC4A transgenic mice. While anti-PD-1 neutralizing monoclonal antibody had minimal suppression on the growth of B16-OVA, antagonistic anti-human CREC4A monoclonal antibody markedly inhibited it. Furthermore, the combination of the blockade of human CREC4A and PD-1 showed a more potent inhibition on the growth of B16-OVA than the blockade of human CREC4A. On the other hand, tumor-bearing mice with a blockade of human CREC4A did not cause any apparent signs of tissue damage of skin, lung, liver, and small intestine when compared with untreated tumor-bearing mice. Collectively, monotherapy with antagonistic anti-human CREC4A monoclonal antibody displays a more potent anti-tumor effect than monotherapy with anti-PD-1 neutralizing monoclonal antibody against the progression of poor immunogenic tumor without apparent signs of IRAEs, while their combinational therapy exerts a synergistic anti-tumor effect. We further addressed the impact of the blockade of human CREC4A and/or PD-1 on the features in the TME in human CREC4A transgenic mice. As shown here, the blockade of human CREC4A or PD-1 enhanced infiltration of CDCs, PDCs, NK cells, CD4 positive T cells, and/or CD8 positive T cells in tumor tissues, whereas it reduced the accumulation of GR1 positive, FOAT positive MDSCs. Furthermore, the blockade of human CREC4A or PD-1 exhibited the reduction in the transcriptional expressions of IL-10, IDO, alginase, COX-2, and MPGES in tumor tissues, Furthermore, the combinational blockade of human CLEC4A and PD-1 not only more profound reduction in their transcriptional expressions than each monotherapy, but also suppress the transcriptional expressions of TGF-beta and INOS. Taken together, monotherapy with antagonistic anti-human CLEC4A monoclonal antibody or anti-PD-1 neutralizing antibody improve the immunosuppressive TME, and their combinational therapy exerts a synergistic improvement effect. We further addressed the impact of the blockade of human CLEC4A and or PD-1 on anti-tumor immune responses in human CLEC4A transgenic mice. As shown here, the blockade of human CLEC4A and or PD-1 enhanced expression levels MSC1, MSC2, CD40, CD80, CD86, B7H1, B7H2, and B7DCs in tumor infiltrating CDCs. Furthermore, blockade of human CLEC4A and or PD-1 enhanced or reduced the proportions of interferon gamma producing MSC1 OVA peptide pentamer positive CTLs or CD4 positive, FOXP3 positive, ROR gamma T positive regulatory T cells in tumor tissues. Thus, monotherapy with antagonistic anti-human CLEC4A monoclonal antibody or anti-PD-1 neutralizing antibody enhanced the activation status of tumor infiltrating DCs and TILs, and their combinational therapy exerts the synergistic effect. This slide summarizes the tumor immunosuppression by tolerogenic DCs and its cancellation by the blockade of mouse CLEC4A4, human CLEC4A, as novel immunocheckpoint molecules expressed on DCs. As illustrated here, TMA generates mouse CLEC4A4, human CLEC4A positive tolerogenic DCs, which cause tumor immunosuppression. Furthermore, antagonistic anti-human CLEC4A monoclonal antibody converts tolerogenic DCs into immunogenic DCs mediated by the blockade of the function of human CLEC4A, and that result in the generation of the effective anti-tumor immunity with tumor rejection. In conclusion, the blockade of human CLEC4A by anti-human CLEC4A monoclonal antibody is expected to exert an effectiveness against tumors with unresponsiveness to the blockade of CTLA4 and PD-1 system with little no severity of IRAEs. Thus, mouse CLEC4A4 and human CLEC4A mediates a negative immunocheckpoint impacting on anti-tumor immunity, and human CLEC4A may serve as a novel promising candidate for immunocheckpoint blockade therapy of tumor in humans to create innovative tumor immunotherapeutic strategy. This research was supported by these grants. Thank you for your attention. If you have any questions, please send me your email.
Today on this strange and significant subject, entitled lipomatosis with hypertensive emergency and angina in suspected TERCAM disease, new association and interpretation, case reports. The learning objectives, starting point or introduction, abstract, vocabulary, or keys for the current case report, case presentation, treatment, discussion, finally conclusion and recommendations. Starting point, the researcher would be lucky if the case report will be including deviation from the straight line. Sometimes the case report takes multiple ways in understanding. The physician should be a strong observer of the new clinical findings. This abstract us to see the impressions for this abstract in the next points. Vocabulary or keys for the current case report: lipomatosis, and there comes disease. The first point. Second point is hypertensive crisis. Lipomatosis, and there comes disease, so that lipomatosis and autosomal dominant genetic disorder in which multiple lipomas are present in the body, several which encapsulated lipomas on the trunk and extremities, but slightly few on the head and shoulders. By 1993, a genetic polymorphism within lipoma was described as a chromosome 12q2q15 with hemorrhagic gene encoding the high mobility group proteinized form IC. Lipomatosis may be associated with Proteus syndrome, Cowden syndrome, beaten gene mutations, benign symmetric lipomatosis or Madelung disease. There comes disease, familial lipodystrophy, hypernomas, epidural steroid injections, and familial angiolipomatosis. There comes the disease, the autosomal dominant with painful subcutaneous adipose tissue disorders. There comes the disease was first described by American neurologist Philadelphia, Dr. Franz Xaver Derkam in 1856 to 1931 as a 51-year-old woman of Irish heritage with severe pain and enlarged subcutaneous tumors on her arms and back. There comes the disease is also identified as adiposis dolorosa, being overweight or obese, emotional instability, sleep disturbance, weak concentration, and difficulty in thinking are reported associated symptoms. Symptomatic treatment is the main option for there comes the disease. Liposuction is a reported choice method, and there comes disease. Second point, hypertensive crisis. Hypertensive crises are acute, worthy elevation of blood pressure that are associated with end organ damage, such as acute myocardial infarction, cerebrovascular accidents, stroke, acute pulmonary edema, or acute renal failure is defined as a hypertensive emergency. There is marked elevation blood pressure or more than 180 over 120 are common issues in emergency departments. It represents the most urgent danger to those applicated versus the essential needs for life-saving and hypertensive therapies. Immediate diagnosis and appropriately aggressive management are essential. Case presentation, line and history, 50-year-old furniture worker, married heavy smoker, male Egyptian patient, was presented to the physician outpatient clinic with acute chest pain and severe headaches. The chest pain was ischemic. He gave a recent history of eating adulterated honey bees for about 3 hours. He also gave a history of several body soft, painful subcutaneous masses since about 25 years. Confusion, difficulty in think, insomnia, and headaches are common intermittent symptoms for this patient. Physical examination. On general physical examination, generally the patient is anxious and he seemed obese. Vital signs: regular rapid pulse rate of 64, blood pressure of 200/130, respiratory rate of 17 per minute, GCS of 15, temperature was normal 36, and oxygen saturation of 97%. There are multiple lipomas in different body parts. No more relevant clinical data were noted during the clinical examination. This is an image of photo for the patient for both arms. And you see multiple soft tissue lipomatous lesion in both forearms, which variable in size and tender palpation. Workup for this patient, the initial ECG showing normal sinus rhythm with a CT elevation variant, CT elevation in V1 and V2 and V3. This is a normal variant, not a characteristic for there comes this or lipomatosis. Echocardiography was done on the second day presentation, showing left LVH, left ventricular hypertrophy, sclerotic thickened mitral valve, as you see in the echocardiography images, MRI, and mild mitral regurg with diastolic dysfunction, but the ejection fraction of 6.2 within normal limits. Laboratory investigation, there is no abnormality in CBC, troponin, renal function, random blood sugar. Only there's mild hypokalemia, 3.4, as you see. The most probable diagnosis for this case is lipomatosis with hypertensive emergency and angina and suspected Derkam's disease. Treatment. He was treated with oxygen inhalation, 100% by nasal cannula, 5 liters per minute, and 1 sublingual isopide dinitrate tablets, 5 milligram. The patient maintained monitoring in the physician outpatient clinic for about 2 hours. He refused to referral to the ICU. He monitored in the physician outpatient for about 2 hours, till controlling the blood pressure. After controlling the blood pressure, sub-Q, enoxaparin, labetalol, captopril, asbocid, clopidogrel, and the nitroglycerin retard capsules were added for the management The patient was continued. After that, after controlling for the emergency for this case, on the above treatment for about 3 days at home, and continued on Labipres tablet, nitroglycerin, retard capsule, aspirin, and clopidogrel. Further cardiac and surgical follow-up were advised for this case. Discussion. A middle-aged furniture worker, married, heavy smoker, male, Egyptian patient was presented to physician outpatient with angina and hypertensive crisis with associated lipomatosis. The primary objective for my case study were the presence of angina and hypertensive crisis with associated lipomatosis in a heavy smoker, male patient in the physician outpatient. Secondary objective for this case study, how to manage this case in outpatient, despite it is a case of ICU. Interestingly, the presence of several body, soft, painful subcutaneous lipomas, confusions, difficulty in thinking, insomnia, and headaches are chronic intermittent symptoms. Obesity and chronic use of analgesics for headache with no response will strengthen the higher suspicion for the diagnosis of Derkam's disease. Think the history of eating adulterated peas is a very important point for this patient, maybe supporting the diet. So hypertensive emergency and angina probable after this diet. Neurofibromatosis type 1 was the most probable differential diagnosis for this case study. Clinical differentiation will exclude it. I cannot compare the current case with similar conditions. There is no similar or known cases with the same management for near comparison. The only limitations for this current case are the inability of tumor biopsy. Acknowledge by Engineer Ahmed Ubari for his technical acknowledgement. Conclusion and recommendation: the association of hypertensive emergency and angina in a heavy smoker, middle age male patient with lipomatosis and suspected Derkam's disease is highly interesting in new association in the current case study. Not all think that eating adulterated honey peas and it is a relation to induce hypertensive emergency and angina are considered. It may be a doubt. At the end, thank you very much. Any question?
As well as the total number of patients with bone metastasis disease. In according to Keynote 24, over the past 15 years, the median survival has almost tripled. Such considerable achievements are made possible by drivers mutation that allow personalized therapy for lung cancer. So treatment of metastasis disease is absolutely palliative and includes chemotherapy, immunotherapy, and target therapy. As well, the main type of treatment for patient this category is absolutely systematic anti-tumor therapy. And local treatment of spine metastasis include radiotherapy and surgical treatment. When thinking about local treatment, the first question we answer is whether to use surgery or not, and if to operate, then to what extent. These questions are very difficult in our practice. Many factors of the anamnesis and clinical picture allow us to answer this question, especially the pain syndrome, neurological deficit, and instability. The design of local treatment, we are used to estimating neurological status, radio and chemosensitivity, stability and instability score. And we are pretty good in it. However, at times we get into troubles with predict survival and understanding of the surgery benefits. The most challenging issue is determining the oncological prognosis. For patients with short survival times, performing extensive surgery is pointless, whereas in some cases we may deprive the patient of normal activity by misjudging the prognosis. There are a large number of prognostic scales of assessing survival, but they do not take into account the characteristic of the tumor and sensitivity to therapy. They are existing scales from different authors. There is an example of our scales calculator for the prognostic and making decision, which takes all aspects of tumor biology. Our research 126 patients with lung cancer who had local treatment for spine metastasis, surgery, local treatment, surgery and radiotherapy alone. Outcome, survival, functional result, quality of life, complication, and prognosis factors. So 50% of patients had been treated both by surgery and radiotherapy. 30% patients had been treated only by surgery and 20% only by radiotherapy. The study has shown that patients were morphologically divided into following groups such as adenocarcinoma wild type, adenocarcinoma with translation ILK gen 20%, and adenocarcinoma with EGFR mutation 28%, small cell carcinoma and small squamous cell carcinoma as well. In our daily practice, we using a variety of pretty effective scoring system to predict survival, such as Takahashi, Tomita, van der Linden, Bauer, and so on. However, that scoring system absolutely ignores the possibility and achievements of chemotherapy, which have dramatically improved survival. That is the reason why the present patient with lung cancer tend to get into poor prognosis group using these strategies, but they live much more longer. To clarify sensibility and specificity of scoring system, we were comparing live extensive according to adaptation scoring system with objective survival. Based on study, we have come to realize that such scoring system can be used, though they have low sensitivity and specificity. According to the result, overall 1 year survival is 68%. This category patient 2 years survival 23% and 5 years survival just 3%. The study has shown that 2 years survival from local treatment, depending on the morphological and molecular type of tumor, was unpredictably higher in patients with EGFR mutation and translocation in ILK gen. Although we can note that overall survival in radiotherapy group tends to decrease, we did not find any statistically significant difference in overall survival depending on type of local treatment, absolutely independent on statistically sampling. The study identified prognosis factors that affecting survival, such as morphological, molecular type, metastasis zone, number of spine metastasis, performance status, number, systematic therapy lines before spine incident. After analyzing the influence of the factors of prognosis, we have selected two groups: correlation with increase in survival and correlation with reduced survival. This algorithm allows more accurate prediction of survival and enables a more considerate treatment for oncological orthoped. In case patients get into a good prognosis group, big surgery is justified. Therefore, when patients get into a poor prognosis group, big surgery is not justified. It seems to be more effective to choose whether a conservative or minimally invasive local treatment. All patients asked about quality of life by questionnaire, namely SF36, QLQ, and Spine Oncology Study Group Outcome Questionnaire. Survey has shown that after surgery, 23 parameters from 29 has become better in the surgery group. In compare quality of life with different type of treatment, we found out that surgery and surgery pulse radiotherapy has shown the best result compared with radiotherapy alone. Considering moderating rate of survival in patients with lung cancer metastasis to spine, they are subject to surgical treatment which support functional result and improve quality of life. Choice of the type of local treatment should be determined by neurological orthopedic state and, of course, oncological space and relevant scoring system. Thank you for your attention.
Thanks, Dr. Andre, for your presentation. That was an excellent presentation.
Novel Glucose index. What's Glucose index? So first of all, nasopharyngeal cancer rank as the 23rd most prevalent form of cancer globally, and concurrent chemotherapy, radiotherapy, and intensity-modulated radiotherapy has superseded radiation alone or substantial chemoradiotherapy regimens in the treatments of medically fit nasopharyngeal cancer. There is a substantial improvement in local regional disease control and survival rates, and as well as a notable reduction in most severe toxicities. Radiotherapy can cause a number of oral toxicities, including radiation carriers, osteoradionecrosis, hyposalivation, dysgeusia, dysphagia, trismus, and tooth loss, as usual. And radiotherapy and concurrent radiotherapy have been known to cause significant damage to teeth, vascularization, and supporting tissues, inevitably leading to tooth extractions and a decline in oral functions and related quality of life measures. So, pre-CCRT tooth extractions have been recently shown to be associated with weight loss, significant weight loss during a concurrent chemoradiotherapy course in oropharyngeal cancer. Tooth loss before, during, or after oncological therapy may not only impair oral functioning, but also contribute to malnutrition and a poor disease prognosis and overall survival. It's essential to assort new biological indicators to precisely predict the likelihood of tooth loss at any point throughout cancer treatment, which might facilitate the timely implementation of preventative or therapeutic interventions for those patients at high risk. On the other hand, periodontal disease and dental caries are the most common causes of tooth loss, and inflammation plays a crucial role in both. Some inflammatory markers, such as high glucose levels in blood, can cause microvascular and microvascular changes that lead to periodontal disease and compulsory tooth extractions. Elevated levels of CRP and established marker of acute and chronic inflammation strongly indicate the presence of destructive periodontal disease and inevitable tooth loss. So another acute phase reactant protein that may be associated with tooth loss rates is albumin. So we prepare index and predict an index for prediction of toxicities like radiation-induced tooth loss, and we named it Glucor. Glucor fasting glucose, CRP, and combine of phased glucose, CRP, and albumin. We think Glucor index mechanism. First, hyperglycemia can contribute tumor-related inflammation by triggering these release of pro-inflammatory cytokines such as interleukin 6, interferon, tumor necrosis factor alpha, and resistin, and this can ultimately result in a mitochondrial dysfunction, oxidative stress, the build up lipids within liver or skeletal muscle cells, and decrease in beta oxidation. These events may lead to development of insulin resistance and the activation of downstream carcinogenic signaling pathways. What is the hyperglycemia mechanism on tooth loss? Hyperglycemia may also cause immune dysregulation by diminishing the functions of immune cells infiltrating cancer tissues, including CD8 plus T cells, neutrophils, and myeloid derived suppressor cells. These cells regulate M1 and M2 differentiation and stimulate interleukin 6 secretion by inducing TNF-alpha secretion by monocytes and macrophages. These hyperglycemia functions may lead to aggravated inflammation, immune suppression, tumor growth, tumor progression, and infiltration. Also, hyperglycemia can play a predictive role in impeding apoptosis in tumor cells, which is brought about the specific inhibition of serine 46 phosphorylation, a known activator of P53, and cytochrome C-mediated apoptosis by glucose-induced increased glutathione synthesis in tumor cells. Hyperglycemia may induce or accelerate malignant behavior by increasing reactive oxygen species production in a concentration-dependent manner by accompanying increases in ureakinase, fibrinogen activator, and superoxide dismutase dependent hydrogen peroxide. High glucose levels may additionally promote cancer stem cell properties via activation of transforming growth factor beta, TGF-beta, signaling pathways, thus synergically increasing tissue fibrosis, cell invasion, migration, and metastasis in tumor cells, creating a treatment-resistant PDAC phenotype. Excess glucose may bind non-enzymatically to amino groups on nucleic acids, lipids, and proteins, forming precursors of advanced glycation and products, and the degree of which is related to severity and duration of hyperglycemia. Hyperglycemia also causes long-term AGE buildup and increases intracellular inflammatory signals, which promotes NF-key beta activation and oxidative stress, and ultimately leading to carcinogenesis, initiation, and advancement. CER mechanism, combination of CRP and Albumin. CRP is a protein manufactured in the liver and activated by pro-inflammatory cytokines during the acute phase of an immune response. CRP, it is also widely acknowledged as a non-specific but robust and dependable marker of systemic inflammation in the host. The upregulation of this protein is invariably accompanied by a rapid disease in decrease in blood albumin levels and leading hypoalbuminemia. This inverse relationship with CRP and albumin levels is attributed mainly to suppression of albumin synthesis and hepatocytes caused by CRP and by its products, tumor necrosis alpha and interleukin 6, which can be utilized in monitoring the severity of inflammatory reactions in various pathological conditions. Elevated CRP and reduced albumin levels also indicate a precachectic and cachectic states in patients. Our aim is to evaluate the value in this study is to evaluate the value of newly created Glucker index in predicting tooth extraction rates after concurrent chemoradiotherapy in locally advanced nasopharyngeal carcinomas. The Glucker index was defined as Glucker fasting glucose, CRP, and albumin ratio by utilizing the measures of glucose, C-reactive protein, and albumin obtained on the first day of concurrent chemoradiotherapy. Access to pre and post CCRT dental and panoramic radiography examination records was an absolute requirement for eligibility of patients. Radiography examinations were performed using panoramic scans as a part of standard dental care for every head and neck cancer patients following the introduction provided by manufacturer. Teeth had no periodontal support, were too decayed to be restored, and had apical lesions that were too large to be treated with root canal treatment were extracted. Shallow tooth decay lesions were treated with the use of dental fillings, and the patients received instructions on oral hygiene practices, and dental scaling procedures were conducted to promote the ongoing maintenance and enhancements of oral hygiene. The radiotherapy doses were, as presented earlier, high, intermediate, and low risk planning target volumes, such as 70, 59.4 grades and 54 grades, respectively, delivered in 33 daily fractions without treatment on weekends. And each patient's clinical and radiological examination data were recorded at post CCRT 1, 3, 6, 9, and 11th month, and subsequently at every scheduled 3-month interval or whenever necessary. In this study, 187 individuals diagnosed with locally advanced nasopharyngeal cancer who underwent CCRT. The age range of for total study was 18 to 78 years, with 56 years as the median age. In the whole study, 68.4% were male, 68.9% has smoking consumption and smoking habits, and 57.8% have of patients have alcohol consumption, and all patients received a comprehensive dental evaluation before CCRT, ADA, and FDA. The majority had 3 to 4 tumors and 2 3 nodal stage of disease. All patients underwent pre-CCRT dental extractions with a mean of 16 days between the tooth extraction and the initiation of CCRT. Or in the patient population, the percentage of 20.3 had diabetes, and the median fasting glucose measure was 98 milligram per deciliter, and the median CPR and albumin measures are 5 to 3 milligram per deciliters and 38 37.2 grams per deciliter, respectively. We use a ROC curve to divide it into the whole population into two groups. Our optimal glucose cutoff was 31.8, and it's divided the whole study cohort into two groups, Group 1 and Group 2. A comparison between two groups found that the tooth extraction rate was significantly higher in the group with a 31.8 and higher group. The group 2. The mean follow-up time was 48.3 months, and 148 patients received 2 to 3 cycles of concurrent chemotherapy. 136 patients received 1 to 2 cycles of adjuvant chemotherapy, and tooth extraction was performed in 69% of patients during the follow-up period. The univariate analysis, a statistically significant association was observed between the rates of tooth extraction after CCRT and MMD, equivalent a higher 38.5 grays group, and the mandibular V55.2 grays and 40.5% group, and presence of diabetes mellitus. In the results of multivariate analysis indicated that each of the 4 characteristics examined remained significant and independent predictors of higher tooth extraction rates in patients with locally advanced nasopharyngeal patients treated with definitive chemoradiotherapy. So, as a conclusion, the newly developed glucose index is a dependable biomarker that usefully, successfully predicts the occurrence rates of post-CCRT tooth extractions in patients with locally advanced nasopharyngeal cancer, and it may present a significant milestone in identifying high-risk patients and may pave the way for the design of potent preventive measures and follow-up algorithms if further studies validate the results presented here. Thanks for your attention. Here is the QR code of our study, so you can read it by now. Thank you. Thank you.
Thank you, Dr. Efsun Somai. That was an excellent presentation. So, are there any questions for Dr. Efsun Somai from the audience?
With the audience here, as an experience for the workers working in this area, and for especially sharing it with the patients who are suffering from this multiple myeloma. And this is a prelude. That's why I give in the first slide that I myself is a patient of multiple myeloma. And although it is a long treatment period, but I will try to share the most significant parts due to the short presentation time and for the sake of the benefit of other patients. Now, I will not go in detail because now it is there is a lot of literature on multiple myeloma, but briefly I should just mention some of the important points that multiple myeloma is a treatable but still incurable hematologic malignancy, and it is caused by the outgrowth of the monoclonal plasma cells, leading to the damage in the bone marrow. Plasma cells usually develop from beta cells or B cells found in the bone marrow. When they begin to grow in an uncontrolled manner, they start producing abnormal proteins, causing destructive bone lesions. Besides bone lesions, they can cause kidney injury, anemia, hypercalcemia, plasmacytomas. They all result in tumor growth of plasma cells. Developments in the treatment of newly diagnosed multiple myeloma have improved in the recent decades, and the survival age of such patients significantly in the last decade has increased. This is the better part of it. So the initial impact came from introducing several medicines for the multiple myeloma like thalidomide, bortezomib, and lenalidomide. Sometimes a combination of many other drugs like carfilzomib, pomalidomide, ixomib, CAR T-cell, teclistamab, etc. These therapies have been developed recently and they are approved by the FDA for the treatment of multiple myeloma, and they are very promising with improved outcome. So obviously my treatment started with cyborg cycle, and these cycles are mentioned in the results table 2 and table 3, which I will discuss briefly. And also the teclistamab, which was recently approved by FDA. I had my treatment with this drug also because my multiple myeloma was relapsed, and it was very effective in such conditions. So that's why I will discuss the teclistamab also. And teclistamab is a bispecific antibody and targets both CD3 expressed on T cells as well as B cells maturation. So that's why it is the first, being the first bispecific antibody directed to the T cells as an approved for the relapsed or multiple myeloma. I will discuss it also. So this presentation describes my personal experience, as I said in the beginning, and I hope myself as well as the others to have a longer life on a maintenance dose of the present cycles with drugs with a better life quality. So briefly, my case is such that in mid-2019, I started developing low back pain, and it got worse day by day, limiting my daily activities. Then gradually, bilateral pain developed in my shoulders and ribs, especially in the right lower ribs, limiting my movements. Even analgesics were ineffective in relieving pain, and I started sleeping on my left side to avoid the pain. So these are the symptoms which gradually developed. I started losing my appetite, fever all day, fatigue, malaise, lost more than 8 kilograms of body within 3 months, and had polyuria and nocturia. Even I experienced pain in my thighs when I changed posture from sitting to standing up. So then ultimately I sought medical advice and was seen by neurosurgery and orthopedic clinics. They recommended for an MRI, and which was done on November 2019, and they prescribed analgesics for the pain, but it was of no relief. Finally, I visited the emergency of my university medical city. So based on the above symptoms, which I just now briefly described, I was admitted to the emergency and with a suspicion of multiple myeloma for further investigation and diagnosis. So my diagnosis was done on December 15, 2000, at the age of 64 years. All the laboratory investigations and imaging required to diagnose multiple myeloma was, it is all summarized in table 1, which is the next I will show you. Furthermore, the hospital treatment course as an inpatient after the diagnosis was done brilliantly, and it is summarized in table 2. And then further, I was discharged with a plan of action, how the treatment will go. So the table 1, you can see it is a long list. This is the main laboratory test. There are so many results. I cannot include all of them here, but if you see the urine Benz-Jones proteins, it was positive, found positive. Creatinine was very high. And then kappa-free light chains, they were, I mean, the average range is from 3.3 to 19. It was at 18,000, more than 18,000 at that time. So on the basis of these 3 main and the other indicators, I was diagnosed as a multiple myeloma patient. And then I underwent treatment according to my consultants and doctors very aptly. And I was put onto various doses. You can see dexamethasone, bortezomib, and dosings are here. I will not go in detail, pamidronate and other things, but it all helped and it improved. And my FLC also came down and I started feeling better. So these are the protocol for the 8 cycles of the cyborg, which I received from January 2020 to July 2020. And they were very helpful. And you can see from my FLC, it came down from 18,000 to 7,000, which was a very significant improvement. And then with the plan, as I said, I was discharged, but I still continue. And from that day, I continued on a weekly cycle treatment in the daily care unit of the oncology section of this university medical college. So my kappa FLC, kappa lambda ratio, they decreased significantly. It is shown in table 3 and figure 1. I will show you. And further on, I was treated with 12 cycles of bortezomib and dexamethasone, and kappa level also was coming down to 2000, as I said in figure 1, you will see. Then after 2020, from October 2021, I went on a drug vacation with the consult of my doctors after discussion. And unfortunately, this resulted in a relapse in a refractory multiple myeloma. So increasing my FLC to 8,000. From 2,000, it went up again to 8,000. Here you can see the kappa. So this was up to 18,000 and it came down. But in 22,000 to 2022, it was relapsed here. As you can see here, it rose again. Similarly, the ratio, accordingly, the ratio was shot up here and it was relapsed. So immediately, with the consent of the team of my doctors, and they all switched me to Velcade and other cycles, and DKD and KRD, they were taken as the cycle treatment for me, which brought down the condition, and my FLC decreased again below 2,000, and it was a good sign. But then thereafter, it remained stable, and it did not, go up or down. So that's why since May 2023, 8 cycles, teclistamab from January 2020, it was started. because teclistamab is specifically effective in the relapsed condition, and I fulfilled all the conditions for the teclistamab, that I should have completed lenalidomide and other 8 cycles of my treatment. So under such condition, I was treated with 9 cycles of DKD after relapse. And then I was switched to the 5 cycles of KRD, which is carfilzomib, lenalidomide, dexamethasone. These were the conditions on the basis of which my teclistamab treatment started from May 2023. And subsequently, I was admitted in the hospital to start the teclistamab, because teclistamab cannot be given as such. It has to go through a step-up dose therapy to monitor any CRS or ICANS, respiratory infections or nervous side effects. There are a lot of side effects of it. So I was monitored for it, and I didn't develop any complications. So I switched on the teclistamab dosings. So as I said, time is short. There are many laboratory data results regarding with the prognosis and treatment of multiple myeloma. It is impossible to include or describe all of them here. But the salient and important results and markers related to my disease and my treatment are already mentioned in table 1 and 3, which I discussed shortly and briefly. But still, I would like to mention that all therapies, including the chemotherapeutic cycles that were used throughout my treatment since the day of the diagnosis, they were shown in table 4, and they were very effective. Here in table 4, you can see diagnosis was in 2019, sorry. Then the cyborg, bortezomib, DKD, KRD, teclistamab. So they were all taken up gradually in a chronological order. And you can see kappa from 18,000, it came down to 2,000, and then it was relapsed, and then again it came back. And then finally in the in February, January, February, and March, during the teclistamab treatment, my kappa, yani the FLC, was stable, but it started creeping up again. So it started creeping up very gradually, and it rose up to 300. And thereafter, my teclistamab was stopped, and I was switched to pomalidomide with 4 milligram capsule with 2 weeks on and 2 weeks off cycle. And now, at this stage, my FLC is under control within normal range. So this is what the current situation is with me. My FLCs are under control, and all the laboratory tests, they are under control. And here I would like to mention that one of the important marker for the multiple myeloma patients is the creatinine. And this creatinine, another significant marker, which is the nephrological functioning of the kidneys, and it is important related with multiple myeloma. In the figure 2 here, you can see here, in 2019, creatinine was very high, above 400. And then it came down. Now it is almost at a plateau up to present day. Although it is higher than the normal range, but my nephrologist and the other team of doctors and consultants, they are I'm satisfied with it. And I also don't feel any problem in urination or any kidney problem. So it is stable, and my treatment is going on, and I feel comfortable, and I hope that I will get through it for a better life age for me. So important thing to discuss here is that the incidence of severe CRS or CNS, respiratory, etc. infection was higher in the real world as compared to seen in clinical trials for the multiple myeloma patients. So it emphasizes that during the treatment, the use of primary IVIG prophylaxis is important. And this is what I am receiving every month. Monthly IVIG support with the teclistamab before and now with the pomalidomide is controlling my infections, and I'm not getting any significant secondary infection, although I'm taking other medication, prophylactic, antiviral, antibacterial, antifungus. So I'm taking that daily. So at present, I am receiving 4 milligram of pomalidomide cycle once daily for 2 weeks and skipping for the next 2 weeks, that is on and off mode with monthly IVIG with no observable side effects, which itself is a very encouraging outcome to date. So, and creatinine I have already discussed, although it is high, but it is at a plateau and I have no problem in kidney, any kind of this. So this reflects the minimal side effects of my treatment medications throughout. However, there is no problem experienced in urination, etc. And I have been monitored in the past and in the present also very, very effectively by my team of doctors. They are taking a good care of me, and I myself and my family, they are all taking a very good care of me. So the conclusion is that the purpose of compiling the salient features and results of my prognosis of multiple myeloma treatment is to emphasize the visibility of a successful treatment schedule. It is possible. Although it has not been claimed to be cured, but the present cycles of treatments represent a possibility of longer follow-ups with maintained disease-free status, especially on relapsed conditions. So my personal experiences might contribute some positivity to justify the reported trials that include measurement of minimal residual disease with the identification of the best therapeutic approach for relapsed or condition of the multiple myeloma soon. So this is what I conclude, and I hope it will be, my observations will be contributory in other projects which are going on worldwide for this multiple myeloma. So this is, I especially take this opportunity to thank my consultants, doctors, nurses of the medical daycare unit at my university hospital, and all my family members for their outstanding care. And I also thank my deanship of my college, because I'm a professor in College of Nursing Research Center, and I acknowledge the help of all others. Thank you very much, and I pray that all of you stay safe and healthy.
Originate from the terminal ductal lobular unit. And now I'm going to talk about the so-called invasive lobular carcinoma, which is once again a misnomer because it has nothing to do with the lobules. Long-term survival curves are extremely important to communicate the message. This is 39-year-old survivals. We talked about how skillful we were, the whole diagnostic and therapeutic team members, in finding breast cancer earlier when it originates from the terminal ductal lobular unit, the survival curves are unique. No previous generation of physicians could ever produce it. But you see, the same radiologists, same surgeons, same oncologists, technologists could not control this disease. And this one. This is the cancer originating from the major lactiferous duct. And this one is erroneously called invasive lobular carcinoma. Fortunately, this accounts for only 5 to 8% of the cancers, but it's very difficult to find, even if it's a fatty replaced breast. Here, there is an 8-centimeter carcinoma. And the imaging biomarker has concave contours, while the imaging biomarker of the AABs always had convex contours. We wanted to learn more about this very peculiar type of breast cancer, and we compared to those imaging biomarkers that we found in AABs, in acinar adenocarcinoma of the breast. This one, although 8 centimeters, 7 centimeters, always has concave contour, while this one can be 5 millimeter and it has convex contour. This may have some calcifications. This never has calcifications. Cancer originating in the major lactiferous duct, 4 out of 6 biomarkers have calcifications. This never has calcification. The conclusion is, it has to originate from a different site. When we think logically, if it doesn't originate from the TDL, it doesn't originate from the ducts, there are the 2 supporting tissues, the adipose tissue, as well as the mesenchyme, the fibrous connective tissue. Certainly, it cannot originate from the fat. This led us to the inescapable conclusion. This very peculiar breast cancer may originate from the stem cells of the mesenchyme. When you are looking at this histology image of so-called invasive lobular carcinoma, we call it invasive breast cancer of mesenchymal origin, then you are surprised that the pathologist never showed you the normal cells in the terminal duct as well as in the acini. They only shows you the single files, the cancer cells. The picture in front of you make it very clear that these cancer cells could not have originated from these cells because these are normal. So what justifies the term invasive lobular carcinoma? Saying invasive lobular carcinoma, you imply that it originates from the lobule. But this is a lobule, and the lobular cells are normal. Normal epithelial cells lining the terminal ducts, and here are the cancer cells in abundance. The cancer cells may surround the terminal duct and the acini in a targetoid pattern. Inside, there is normal fluid, and there are the normal epithelial cells in the terminal duct and in those few acini. The rest are cancer cells. So these cancer cells could not have originated from the epithelial cells of the lobule. The term invasive lobular carcinoma is not justified. You see here the most beautiful presentation of normal fibrogranular tissue. The white is the supporting tissue fat. The yellow is the supporting tissue fibrosis, mesenchyme. If we take a mammogram, then we can see that these nodular densities measuring about 1.5 millimeter correspond to the terminal ductal lobular unit, which one day produce the milk. So if the peculiar cancer doesn't originate from the TDLU, it doesn't originate from the ducts, and it doesn't originate from the adipose tissue, this is left, the mesenchyme. Dear colleagues, what I'm showing now are normal mammograms. concave contour fibrosis. They are supporting the TDLUs and the ducts inside. But when this breast cancer of mesenchymal origin develops, we see thousands and thousands of layers of sheets, veils, tightly packed over each other. And it makes the radiologist very sad that the concave contour is still maintained, making it very difficult to detect. When you go to a tumor board, the pathologists are entertaining you with these single phials, Indian phials, but you as a surgeon do not see those cells, do not palpate those. The breast imager cannot see cells on the mammogram, but the physical examiner can inspect and palpate a tremendous change of the breast, which has a very firm thickening. If I'm not palpating the cells, what am I palpating? What the pathologists don't talk about, namely this extreme amount of mesenchyme. Layer after layer, squeezing, forcing the cells go in a row instead of sitting in nests. And eventually, there is a shrinkage and there is thickening. From a radiologist's point of view, this is kind of spider's web. There is no central tumor mass. Difficult to detect even if it's extensive. This is why we call it spider's web, like uncombed hair. The pathologist outlined the extent of the disease between the skin and the chest wall. For you, the clinician, it's recently detected extensive firm thickening. Palpation and inspection give the same impression that this tissue inside acts like scar tissue that shrinks the breast and influences the MR as well because it squeezes the vessels too. You performed mastectomy and look what the large section histology tells you. Cancer cells all around the margin. We came up with this idea that the mesenchymal hybrid cells, stem cells, could transform and produce fake epithelial cells. We had a 3-year-long cell culture study, and we published the results. Please read it. This is Article 5 in our series. You have these lectures. I sent it to your leaders. The stem cells are right in front of you. We published Article 6 and also Article 10. Look at this shrunken breast because of this diffusely invasive breast cancer of mesenchymal origin. I'm going to serve you one bad news after the other. The cancer is very extensive here. Here is the 3D picture of this very same. And the first bad news is that these patients run a 40% risk of dying from breast cancer. Another bad news is that whatever you have done and we have done in the past 3 decades, there is no improvement in survival. Why? Partly because you are sending these patients for radiation, and look at the difference between not received and received radiation. Difference is 0. And you are sending them to chemo with all the side effects. It's resistant to post-op radiation and chemotherapy. That's why the long-term outcome of these patients did not change during 3 decades. Pharmaceutical industry always promises improvements, not in this breast cancer subtype. I'm just wondering whether you are familiar with this gene damage, Cadherin-1. When you see a patient with bilateral breast cancer of mesenchymal origin, please refer your patient to the gastroenterologist because it's likely that she also has linitis plastica, about 56% of the cases. And here, the pathologists are talking about the increased amount of fibrosis in the breast. They rather talk about the cells. Both of them have the cancer cells as well as the excess amount of fibrous tissue that is going to stop the peristalsis in the stomach or in the colon. Question: are these pictures very similar to each other? Yes, they are. But these are from the breast, and these are from the stomach. The radiologists have an expression to describe this stiffened wall full of fibrosis as leather bottle stomach. It really is like a leather. It's an enormous amount of fibrous tissue. This breast malignancy is so exciting, so challenging, we wrote a 3D book about it. A case is coming up for you. She's 81, self-detected large retroareolar thickening. You can guess why she was scheduled for colon surgery. The case is very simple. You see a huge central architectural distortion, retraction of the skin, retraction of the nipple areola. Ultrasound is the procedure of choice in these cases because the ultrasound beam is sent back immediately due to the large amount of massive fibrosis. Architectural distortion, imaging biomarker of BCMO. Easy target, invasive breast cancer, already on the core biopsy extensive LVI. And look what the pathologist says. Your pathologist is taking this and this and this and throws away the rest. This way you will never learn. Yes, there are the cells here marching in a row, but my eyes are on this red, excess amount of fibrous tissue. A very good comparison between the black and white and the color, but no radiologist would say that all this is cancer, but it is. And here it is again, the targetoid pattern and the terminal duct with totally normal cells. 7 centimeter diffusely invasive BCMO. The immunohistochemical biomarkers are going to fool you because they predict very good outcome. However, already at the time of surgery, there is extensive LVI and multiple nodes positive. And unfortunately, immunohistochemical biomarkers fooled you totally. The patient developed cerebral and lung metastases and died from breast cancer within 2 years. Don't trust the immunohistochemical biomarkers, luminal A, B, in diffuse cancers. You look at the imaging biomarker. Anybody can say, this is bad news, especially if you work with a good pathologist who provide light section. Why is it so that the E category is negative in these transformed cells and they are positive in her own epithelial cells? Because these cells, although may give the impression that these are epithelial cells, but they are fake. They are the wolf. The pathologist thinks this is a sheep. No, this is a wolf in sheep's clothing. Her own epithelial cells develop when she developed the breast. They are going to react to the immunohistochemical biomarkers correctly because they were designed, manufactured and tested primarily on those tumors that originated from those epithelial cells that she had during her life. The fake epithelial cells are not going to have the same reliable set of immunohistochemical biomarkers because these are stem cells. One of my patients had invasive breast cancer mesenchymal origin in one breast and a tubulocarcinoma and AAB in the other one. You see the size here. And you can see the predicted outcome. In the right breast, dismal. In the left breast, she would not die from this disease. While I look at a mammogram, I can see this difference. It's a stellate lesion, and this is a huge architectural distortion. But when I'm looking at the immunohistochemical biomarkers, I get the very same picture. This is useless, predicting the long-term outcome. One more issue to talk with you about. One day you are going to palpate, or the patient comes with this huge, we call extralobular, diffusely invasive breast cancer of mesenchymal origin, and your pathologist says invasive lobular carcinoma. And then you are working with a very good radiologist who can find 8, 9, 10 millimeter stellate lesions to the core biopsy. You remove it, and the pathologist is going to say invasive lobular carcinoma. Excuse me, I see two very different diseases, but you still use the same name. Wrong. 71, asymptomatic, called back from mammography screening, of course, because you work with a good radiologist who says there is no asymmetric density here, so we are going to call the patient back, and it is on this forbidden area. Tiny artificial intelligence reacted, and we do the microfocus magnification, and my very first thought would be AAB. Please keep in mind, a certain percentage of the stellate or circular lesions are actually mini intralobular BCMOs. Easy target on ultrasound. And already here, the pathologist is going to annotate you with these single files. I immediately look at the red, not just the blue. You do very good surgery. It measures 10 by 10 millimeter. But when you look at it closer, yes, it has the single files. It has the fibrosis. But on the other hand, it has entirely normal acini and terminal duct surrounded by the cancer cells. And this is what we call colonies of intralobular BCMO. They build up this 10 millimeter carcinoma, which has normal epithelial cells in the acini and the TDLU and in the terminal duct. E-caterin is going to stain the real epithelial cells positive, but the surrounding cancer cells are E-caterin negative, totally unstained. And the pathologists like the anti-actin staining to demonstrate the myoepithelial cell layer. As you see, the normal acini have normal myoepithelial cell layer. She has a solitary invasive carcinoma. Now, my question is, surgeons, why would you send this poor patient with a left-sided carcinoma? Mind you, behind it, very close, there is her heart. You know that it is going to bring in zero benefit. Don't follow the dogma. Bernie Fisher caused so much harm by dogmatically ordering chemo and radiation. Unfortunately, you gave me just 15 minutes, and of course, I stepped over my time, but fortunately we have a 50 minutes opportunity for discussing your questions. Thank you very much for your attention.
That was an excellent video presentation, Dr. Laszlo. So if the audience have any queries in regards to the video presentation, please unmute yourself and raise your queries.
Hello, Mr. Tabar. I'm Niti. I'm a breast oncoplastic surgeon. I really thank you for
The serious functional and aesthetic defects accompanying these interventions require the simultaneous consideration of the demolition and reconstruction problems. The consideration of the various materials referenced in literature has led our study group to adopt the metal prosthesis principle, the prosthesis being pre-constructed, profiled, and dimensioned for each excised osseous segment. During the operation, the segments of the prosthesis are easily positioned in the residual osseous opening and adjusted to permit firm anchoring to the osseous stumps by means of screws. The schematic representation shows the excised osseous portions depending on the operation as well as the prostheses used. The first illustration shows the resection of the horizontal portion of the mandible and the substituting prosthesis, while the second shows the hemidisarticulation of the mandible and its relative prosthesis. Röntgen cinematography permits this observation of the patient during mastication. The attachment of the prosthesis to the mandibular stumps, as well as the proper positioning of the condyle, can be noted. All the normal chewing movements and associated muscular action are perfectly executed as the patient eats the radiopaque food material. The patient as he appears 2 years after the operation, showing the attained aesthetic and functional results. Resection of the chin arch was performed on several patients with carcinoma of the gingival border in the area of the incisors. The solid anchorage of the prosthesis to the osseous stumps is observable by Röntgen cinematography, and the patient seen here shows the normalcy of his facial characteristics. The hemidisarticulation of the mandible, including the chin arch, was performed on patients with tumors in both the horizontal portion of the mandible and the chin. The following operation is an example of this type of intervention. By orthopantomographic viewing, the lesion is seen to be extended to these mandibular regions in the case of adamantinoma. A tracheotomy is first performed under local anesthetic and the McGill tube inserted, through which narcosis is induced. The operation proceeds with a cutaneous incision beginning at the gonion, 1 centimeter below the prominent mandibular edge, and follows the jawline around to the lower lip, which is sectioned at the medial line. With hemostasis achieved, the aponeurotic muscular tissues of the cheek are separated from the mandibular osseous surface, and the vestibular and lingual mucosae are sectioned free of their respective fornices. The separation of the periosteal membranes reveals the entire osseous surface, including the chin arch, the horizontal portion of the mandible, and the vertical portion up to the coronoid apophysis and mandibular condyle. The bone is gradually freed by the progressive sectioning of the muscles attached to each portion of the mandible up to the coronoid apophysis and condyle. The neoplastic lesion is seen to involve both the horizontal section of the mandible and the chin arch, as was revealed by the radiographic examination. The bone is sectioned at the canine level on the side opposite the neoplastic lesion by means of a Stryker oscillating saw. With the sectioning of the mucosa in the muscles of the oral floor, together with the pterygoidal muscles, the disarticulation of the mandibular bone is complete. The prosthesis is selected from a group prepared beforehand. The length of the rising portion is adjusted and the metallic ogival condyle is attached to it. The prosthesis is made of Coty 68, a biologically inert metallic alloy which affords very high corrosion resistance and has mechanical properties which are greatly superior to other alloys. The condyle of the prosthesis is positioned in the articulation socket, and the forward portion of the prosthesis is solidly fixed to the anterior face and inferior border of the osseous mandibular stump by means of screws. The screws are made of the same alloy as the prosthesis to avoid all bioelectrical and electrolytic phenomena. The prosthesis is centered along the residual osseous opening, and the mucosa and muscular surfaces of the oral floor are reconstructed with individual catgut stitches. The mandibular muscles themselves are sutured along the whole length of the metallic segment. The prosthesis is thus totally immersed and fixed between two solid muscular planes and covered by the mucosa and skin. The final suturing of the lip, as well as all along the incision, is very carefully executed for maximum aesthetic results. The Röntgen cinematographic record in two orthogonal views, taken at advanced speeds, shows the solid
Thank you. Moving on, we have one more video presentation from Dr. Laszlo Tabor.
Decade the outcome. You are using every day the first and the second generation prognostic factors, the tumor size, the node status, as well as the histologic malignancy grade. Quite recently, the immunohistochemical biomarkers have been used to predict the long-term patient outcome. My job is to introduce a third-generation prognostic factor. We are extremely happy that among women who come to screening regularly and are exposed to the most modern therapeutic regimens, there is a 50% decrease in mortality. We have to be intellectually honest and answer the question, why do women still die from breast cancer, despite the fact that they came to screening and they received the most modern therapeutic regimens? We believe that part of the problem is that the current, definitely outdated histopathologic terminology does not take the anatomic site of origin into account. And also the surgical colleagues have to take seriously the distribution of the tumor. I caution you, breast-conserving surgery does not fit them all. Let me introduce to you the third-generation prognostic factors that give answer to this question, why do women still die from breast cancer? Our research group, which I founded back in 1986, met twice every year since 86. We concluded that the imaging biomarkers that are extremely good prognostic factors for the most fatal breast cancer subtypes are underutilized. They are not used as often as they should be. The large section modern histopathology is reflected correctly on the mammogram. So we call the mammogram black and white histology, and we call the histology the color mammogram. Whether it's cancer or it is hyperplastic breast change, like in this case, a radial scar. Anybody can understand the radiologic image when looking at these large format 3D histopathology images. The classification based on the site of origin of breast cancer is a must because there are enormous inconsistencies in the current histopathologic terminology. We have to get rid of this ductal lobular dichotomy. Other basic information is that when we find out the site of origin of breast cancer, then we have a very good prognostic factor in our hands. A very quick teaching about the imaging biomarkers. Dear colleagues, most of the breast cancers originate from the milk-producing terminal ductal lobular unit. The cells that are lining these acini transform to cancer cells, and the ever-increasing pressure distends and distorts the terminal ductal lobular unit. If we are lucky, we can see the calcifications, grade 1 cancer in situ and grade 2 cancer in situ. The first important thing about the incorrect pathologic terminology is that the pathologists call this lobular cancer in situ, but this one they call it ductal cancer in situ. Is this cancer in situ? Yes. Is it a duct? No. When the basement membrane is dissolved, stellate or circular lesions develop, invasive carcinoma. The pathologists are saying invasive ductal carcinoma. No, dear colleagues, is this a duct? No, it is not. It's a terminal ductal lobular unit. So whenever you look at a mammogram or operate a stellate or a circular lesion, and you are going to get the histopathologic report, invasive ductal carcinoma, smile. That pathologist does not know basic anatomy. We trained and taught the radiologists all over the world not only what the cancer looks like, but where on the mammogram the cancers are localized. And the result is in front of you. More and more palpable lesions are replaced with non-palpable lesions, and the result is phenomenon. These sad survival curves of advanced cancers should belong to the past and are replaced with these curves. Caution for the surgeons. Acinar adenocarcinoma of the breast can be unifocal and can be multifocal. Watch out with the multifocality because the fatality rate is 3.4 times higher in stellate as well as in multifocal circular lesions. The second group of imaging biomarkers have their origin in the cells lining the major lactiferous ducts. And they have 6 imaging biomarkers. 4 of them have calcifications on the mammogram. 2 do not calcify, require galactography and or MR, or this is just a non-calcified architectural distortion. Every surgeon is familiar with this type of mammogram, where the whole lobe is filled with comedocarcinoma. Unfortunately, the pathologists call it in situ, but that's incorrect because the fatality rate in these are high, because this is not an in situ cancer. It's a duct-forming neo-duct genesis, invasive carcinoma. The cancer cells are breaking themselves through the basement membrane. I can show you similarities from Mother Nature. Side branches, new ducts are formed. And then the last one, 5 to 8% of the cancers, erroneously called invasive lobular carcinoma, these actually originate from the hybrid cells, the stem cells of the mesenchyme. They are very much different in their histologic image and their mammographic image compared to the acinar carcinomas. They are concave, they are difficult to detect even in fatty replaced breast, and they are huge at the time of diagnosis. Here is the problem again. A high rate of fatality in this group. I answered the question for you. Why do women die from breast cancer despite getting most modern therapeutic regimens? Because some women don't come to screening. and their cancer is not detected at an early phase. But for the surgeons, this is a more important message. Multifocal acinar adenocarcinoma of the breast and diffuse cancers many times are forced on breast-conserving skin and nipple-sparing mastectomy. If we look at the incidence as well as the mortality from the acinar adenocarcinomas, unifocal, multifocal, and diffuse, we got the following result. Although the unifocal cancers account for most of the cases, but the multifocal AABs and the diffuse cancers have 71% of breast cancer death. Compared the matching colors, the yellow in 28% of cancers, 31% of death is because it's multifocal AAB. Even worse, when it's ductal adenocarcinoma of the breast, in 10% of all cancers, 20% of death is. And the worst actor is the breast cancer of mesenchymal origin, erroneously called invasive lobular carcinoma. In 7% of the cases, you find 20% of death. We wrote 10 articles about it. We do not believe that the first and second generation prognostic factors can predict the outcome of the diffuse and multifocal cancers properly. Our research group evaluated the association of imaging biomarkers with the conventional individual and combined immunohistochemical biomarkers. The conclusion is that yes, the immunohistochemical biomarkers predict very well the long-term outcome of unifocal acinar adenocarcinoma of the breast, small or larger, and most of them are luminal A cases. When we use the immunohistochemical biomarkers in smaller and larger acinar adenocarcinoma of the breast, we are not surprised that the predicted and true outcome match each other perfectly. But the problem is that you use the immunohistochemical biomarkers also in the DABs, also in the breast cancer mesenchymal origin, and also in the multifocal cases. And that's wrong. It doesn't fit all. Here is a multifocal cancer. It consists of different breast cancer subtypes. So where does the pathologist determine immunohistochemical biomarkers from? From here? Then you are misled because this is going to have a different set of values. When concerning DAB, unfortunately, the immunohistochemical biomarkers always determined from the associated AAB. But this one jeopardizes her life, and pathologists never determine the immunohistochemical biomarkers from here. And understandably, there is a difference between the predicted and the observed outcome. This is enormously emphasized in the so-called invasive lobular carcinomas. These are moderately differentiated, ER/PR positive, HER2 negative, very low proliferation index. So based on the immunohistochemical biomarkers, this is what we would expect as an outcome. But this is what we get. Don't even use the immunohistochemical biomarkers in predicting the outcome of these cases. It is quite sad that people don't know that when this is the mammographic image, DAB, then most of the cases are luminal A. But there is a 30% fatality rate, and even worse here. In invasive lobular carcinoma, you say, oh, this is a good cancer. But 40% of them are going to die. Please be careful. 21% of all malignancies have 45% of breast cancer death. Dear colleagues, we are not going to make a step forward if we use the archaic small section chopped onion like histopathology technique, you should use the large section. And if you use the 100 years old, anatomically incorrect and therefore misleading terminology, and you believe that the immunohistochemical biomarkers and their combination, molecular imaging and luminal A and B, is going to compensate for not having large section and for using old terminology, you will be disappointed. So our major finding is that the predictive value of the molecular biomarkers is misleading in multifocal and diffuse breast cancers, those that originate from the major lactiferous ducts and those that originate from the stem cells of the mesenchyme. However, the imaging biomarkers immediately point out which is the bad actor. In these cases, the imaging biomarkers should be prioritized over molecular biomarkers and planning treatment. This is our tumor board where we have 4 screens. This is for the large section, low power. This is for the specimen X-ray, the MR, the mammogram, the ultrasound, and this is for the cells. And we constantly correlate the finding with large section histology. Thank you for your attention.
Okay, moving on. The last presentation for the day will be an e-poster presentation from Dr. Gennady Bilonenko, Donetsk National Medical University, Ukraine.